going live. Okay, we're live. You can call the meeting to order when you're ready.
Yeah, we call a meeting to order and we'll take a roll call. Leslie, please.
Good morning, everybody. I'll start with our voting commissioners. Chair Khan,
Present.
Dr. Barron,
Here.
Teresa Bohannon,
Here.
Bobette Bond. I see you. You're on mute.
Barely here. Thank you.
Jessica Flood. I don't see Jessica yet. Flo Khan. I don't see Flo yet. Yarleni Roa Dugan.
Here.
Sean Shaner.
Here.
Dr. Slonim.
Here.
Mason Van Howling.
Here.
Moving on to our advisory commission members. Justin Projak.
Here.
Barbara Richardson. I can see you're signed on, but I can't hear you, Barbara Richardson, and Richard Whitley.
Here.
Mr. Chairman, that concludes our roll call, and we do have a quorum.
Thank you, Leslie. Appreciate it. Welcome back, everybody, for this meeting. As you see, we have agenda items that may be a little long, but we try to time them. So if we try and stay within that time frame, that would be ideal so that we finish in time, because I know everybody is busy and the meeting is already extended to start off with. So hope everybody respects the time and we try to finish in the interest of everybody's time. So having said that, next item on the agenda is any public comment. Anybody in the north? Public comments are limited to 3 minutes, so please respect that.
Chair Khan, let's give the public a little bit of time. If members of the public wish to speak right now, please go ahead and press *9 if you're on the phone to indicate so, or if you're joining us via Zoom, please raise your hand. Okay, Chair Khan, I don't see anyone wishing to speak in public comment.
Okay, thank you. Anybody in the south? Nobody in the south either?
No.
All right, thank you. So then we move along. Item number 3, we've allocated 5 minutes, possible action, approval of the April 21st, 2020 minute, 2020.
Oh, 2021, that was a typo, but yes, it's the 2021. We're still stuck in 2020.
Okay, do I have a motion to approve the minutes?
Chair Khan, I'd like to make a motion to approve the minutes.
Anybody second?
This is Tony, I'll second.
Thank you. Any opposed or corrections or changes? If not, the motion carries. The next item, number 4, we've allocated 20 minutes for that for possible action. Discussion on stakeholder advisory committee to the PPC for the Peterson Millbank program, specifically for sustainable healthcare costs. Possible action includes formation and assignment of members, and the names of potential members are included attached list. Has everybody had the chance to look at the list? It's on the screen also, right? Do I see it? No.
I think, please tell me, I've shared my screen. I'm trying to help facilitate this discussion. Can you just confirm that you can see my screen?
Yeah, I can see
Yes.
that screen. So let's proceed, Sarah. We need to have some structure in this discussion. So as usual, we'll go with individual commissioners after you have given some preliminary comment.
Okay, great. So thank you, Chair Khan, Commission members, what I have done on this screen is outline the purpose and scope. This language is something that you've already seen. It was a part of the language from Bailiff's memo to me, in which I shared with you a couple of weeks ago, and it really does summarize your previous discussion last meeting on the purpose of the Stakeholder Advisory Committee. And just for the public and for clarity and kind of recap, I will state that the purpose of the Stakeholder Advisory Committee is for two reasons. The first being to advise you on the design recommendations for the cost growth benchmark and for additional policy development, including but not limited to implementation of the cost growth benchmark strategy, public reporting of the benchmark performance, and development and implementation of a data use strategy. Secondly, the purpose is to engage stakeholders who are likely to be impacted by the cost growth benchmark strategy so that they are well informed and ready for its implementation in the future. The scope of this advisory committee is really to convene between meetings of the PPC so they are able to receive an overview of the preliminary design decisions and that were discussed at our meetings amongst you, and then also to provide feedback and relay it back to you at the following meeting. What I want to make sure that is clear is please note that this advisory group would not be asked to agree upon any recommendations to the commission. Rather, they're there to provide feedback, and our staff will convey the full range of feedback to you from the advisory committee at each meeting. And
Okay.
so, Chair Khan, if anybody has any questions for clarity as to why, for the purpose and scope, maybe it's worthwhile to pause here and ask if there's any questions before we talk about their recommendations.
All right, go ahead.
Okay.
Anyone, any questions so far on what Sarah has said? If not, then we can move on.
Okay, and so what we have outlined here is, per your discussion, the recommendations for this makeup include 2 per commissioner, and that is this outline. So each of you submitted 2 names, and so this first list is a summary of those recommendations from each of you. What I have done in addition to that is offer for your consideration additional recommendations to expand the advisory committee up to 27 people. What I would like to point out with my additional recommendations is really following your discussion at the meeting to have some state Medicaid person at the table. And so you'll see several names from DHHS, and I think that would give them the flexibility to always having somebody at the table. So for instance, if Ms. Cody Finney is not able to attend one of the meetings, then perhaps Deputy Administrator Young or Phil Burrell may be able to join, and it'll just ensure that they have an opportunity to be at the table for each one of those feedbacks.
So for clarity of the commissioners, these 7 names mentioned here, all 7 do not have to be present necessarily, as I understand, for each committee advisory meeting, but perhaps someone or some of them may be there to answer questions or give input.
Yeah, that's not entirely true. I think that really only applies for the DHHS members.
Yes, that's what I'm
think,
talking about.
Yeah, there are some additional names that I put some recommendations to really ensure that there is a more diverse stakeholders at the table. For instance, there were some gaps that I noticed with the academics. And then also there is a executive director, Tyler Garner from the Children's Advocacy Alliance, is also interested in participating, and I think would bring another perspective that could be quite valuable to this commission, as well as the director, Joseph Greenway from Center for Information Analysis. And so these are my recommendations. I would appreciate your consideration in addition to your 20, just to kind of make sure it's a well-rounded stakeholder advisory.
So to start off the discussion and kind of structure it so we are focused, if I would suggest that we consider these two names that two areas that Sarah is mentioning. Does anybody have any objection to consider them to be on the commission? Then we'll come back to the rest of the names. Any objections to these two missing areas of representation?
No objection.
All right. If we hear no objection, let's go back to the names submitted by all of you. So there were two names presented by each commissioner. Do we have that screen? Yes. And does any commissioner want any amendments, changes, withdrawing of names, or substituting a name from this list, or any serious objections to anybody on this list from the commissioners? Any comments from anybody on this list? Okay, so there are no changes or modifications or second thoughts from the commissioners. If that's the case, so the next step, Sarah?
The next step would be a consideration or of a motion from one of the commission members to establish the advisory group with all members on this list. So it would be a total of 27. It would be these 20 plus these 7. So if everybody's in agreement, I think the next step would be for you to consider accepting a motion should one commissioner want to make that.
Yeah, do we have motion?
I'll make that motion. I think it's a great list. I appreciate all the work that went into it.
Thank you. A second?
Tony, I'll second the motion.
Okay, any objections, comments? None? All right. So the motion carries since there are no objections. Boy, you're moving along pretty good. If it's okay with everybody, do we really need a 10-minute break right now or keep going? We barely got started.
Press on, sir.
All right.
Let's keep going.
Okay, great. So presentation on cost growth benchmark methodology. Sarah, you want to take that on?
Thank you so much. Yes, Mr. So this is actually Mr. Bailiff's presentation, and I believe he has the ability to share his screen. And commissioners, you'll be following along with the PowerPoint that was sent to you. So Mr. Bailiff, I'll turn it over to you.
Mr. Bailiff, just a comment in the interest of time. I hope your presentation doesn't take the entire time allocated, because I would like to have commissioners' input and questions, which is very important.
I can assure you, Mr. Chair, that we will have plenty of time for discussions today.
Okay, great. Thank you.
Yep. Okay. So let me put this into slideshow mode and we will be off. Okay. So we're going to pick up from where we left off last time. This should be a fun conversation for you because we're going to talk about the actual benchmark today and the benchmark value. And so hopefully you will enjoy our conversation. I want to start by just recapping what we talked about during our last meeting. At that time, you developed a initial recommendation, and I want to note that we're going to share everything that you recommended at the last meeting, as well as what you develop as a preliminary recommendation today with that new body that you just approved, and ask them for their feedback. So I just want to remind you of that. So during the last meeting, you had a preliminary recommendation that total healthcare expenditures, which is what we are measuring when we assess performance against the benchmark, will include all claims-based spending from payers to providers, non-claims-based spending from payers to providers, member cost sharing, so that's deductibles, co-insurance, co-payments, and the net cost of private health insurance, which is commercial insurer admin and margin or profit. You also recommended that total medical expense, which is total healthcare expenditures less the net cost of private health insurance, should be reported net of pharmacy rebates. You recommended last time that the listed 6 sources of coverage should be included when measuring total healthcare expenditures. And you recommended that we include state residents who receive care from in-state providers, state residents who receive care from out-of-state providers, and out-of-state residents who receive care from in-state providers. And as we talked about last time, this will distinguish what you are doing from the other states that have not included out-of-state residents. And as I think you also recall, we will do that to the extent that we are able to do so, because out-of-state payers who might be covering out-of-state residents are unlikely to submit data to the state. For example, Blue Cross Blue Shield of Alabama is unlikely to submit data to the state. So this will be to the extent possible for that last population group. All right, so hopefully this sounds a little bit familiar. What we're going to do today is talk about how to establish the cost growth benchmark value. And these are all the topics we're going to walk through. We're going to start by talking about establishing some criteria to inform the selection of an economic indicator that can be used to inform the value. And then I'm going to talk about what are some economic indicator choices, and everything else will flow from there. And if everything goes well, we might actually talk about a recommendation for benchmark values, or at least have an initial conversation about that today, even if we don't make a final decision today. All right, so let me talk about why we would consider economic indicators when setting the benchmark value. So other states have done so. You are not required to do so, but other states have done so because the reason for establishing a cost growth benchmark is the harmful impact that high and rising healthcare costs have on the non-healthcare economy, because it's a major business expense, and the impact that it has on consumers, so the sort of household economy that people experience. And of course, it also has an impact on government, both local government and state government, in terms of the share of state budget or local government that needs to go towards this. So that's because healthcare spending has an economic impact. Other states have looked to economic indicators to inform where to set their benchmark value. Okay, and so it explicitly would link healthcare spending growth with some measure or measures of economic growth. Other states have done this, but I want to note that if you feel that you would like to use some other reference point for setting your benchmark value, you have the flexibility to do so. So I am going to share with you a set of economic indicators that you can consider. But if at some point in time, someone believes that there should be some other basis, either another economic indicator, the growth in the price of gold, or something having nothing to do with the economy, please know that you've got the space to introduce that into the conversation. Okay, so before we talk about some of the economic indicator choices, I want to suggest that it might be helpful to have some criteria to inform the selection. I want to note that there is no objective right or wrong answer to what economic indicator you might want to use to inform your benchmark. Knowing that there is no objective right or wrong answer might be helpful to have some criteria to guide your decision. So I'd like to share as just a suggestion 3 criteria. In fact, they are 3 criteria that were adopted just last week by the parallel body to the commission that exists in Washington State. And so here they are, and you can consider them and you can modify them if you want. So first, the benchmark will provide a stable and predictable target. So everyone will know in advance what the benchmark value will be. And this presumes that the benchmarks that you set, you're going to set over a multi-year time period. As a reminder, the other states have set them for anywhere between 4 and 10 years. So if you are setting them for a multi-year time period, it will be clear what's the value, and the value will be fairly stable, meaning it's going to be neither unpredictable nor highly dynamic, although it might change over the time period. And you might recall I shared examples of other states that have had them change over time. Two, the data that are used for the economic indicator are independent and objective, and you transparently know how they're calculated. And then three, the net impact of using the indicator or indicators, if you want to use more than one, would be that it would lower the trajectory of healthcare spending growth from what it has been historically. So these are my suggestions. You have no compulsion to use them, but I'd like to offer them now for your consideration and some discussion.
Anything from anyone? All right.
Chair Khan, it looks like Dr. Slonim.
Thank you, Sarah and Chair Khan. I appreciate these criteria. I mean, I think that having objective data that's consistent, able to be measured over time, and benchmarked against will be able to be the best way we can kind of level the playing field and make sure that we're doing our work. So I appreciate the criteria upon which we'll create the measure. The one question I have, and maybe this will come up later, is how we will integrate the conversation for things we previously discussed, like, and this may, you can feel free to push me off if this is not the right time or you're going to cover it, right? So things that include the quality contribution, where we have work that has to be made up in the state for things like things that have not been invested in over time. We've talked about that before. So value, which is a compilation of both total cost of care and quality measures, might be a measure, but if this is not the right time, push me off till later.
Okay. Anybody else? Sarah identified?
Yeah. Michael, do you want to respond to that, or?
Yeah, I would.
Okay.
Yeah, those are great questions. So Tony, I think you're raising two different issues. One is we've talked previously about how there's been underinvestment in some areas, and that has had a deleterious impact on quality. So, by setting a cost growth target, we are trying to certainly slow spending. So there are two possible responses. One, in some states, they've said, we want to reallocate spending and put more in certain areas while staying within our cost growth benchmark. So for example, in Connecticut, they set a primary care spend target to double investment in primary care, but also to stay within their cost growth benchmark. So that's an option. Another option is if at some point there's a collective decision that there wants to be people want an increase in spending to invest in a certain area, and that's going to have an impact on the cost growth benchmark 1 year, then the commission could say, okay, we all agreed as a state we wanted to invest more here in 1 year, and that the implication for that means we're going to exceed the benchmark for 1 year, but we view that as justifiable, and that's okay.
Good.
Okay, and I think
Yeah.
I shared the Sovaldi example in Massachusetts 1 year, where they went through their benchmark, but they all said for a good reason.
Yeah.
The other topic you raised is quality and how that factors in. So right now we're just talking about a cost growth benchmark. There are a couple of states that in parallel also establish quality benchmarks, and that's not right now in our current scope of work. But if you as a commission felt that it made sense to have a set of balancing quality benchmarks because quality is as much a part of value as cost is, then I would encourage you to raise that for discussion later on.
Thank you.
Chair Khan, I don't see anyone else with their hands raised. Is there anybody else that has a question?
Okay. If not, we can move right along.
Okay. Right. So I think we answered this question. You feel good about the criteria. So let's start reviewing some options for economic indicators to use as the basis for establishing the cost growth benchmark. So I'm going to share with you an overview of these 4 indicators. And I want to note that they are different types of indicators. So the first one, and I'm going to go into detail on all of them, looks at the macro economy of the state. The other 3 really look at I'll say the micro economy of individual citizens, consumers, patients. They bring a different perspective. There's not necessarily one that's better than another, but they are different perspectives. So I'm going to walk through each of these using a standard lens. So for each of these, I'm just going to clarify, what are we measuring with this indicator? I'm going to talk about if you were to adopt that indicator as a basis for informing your benchmark value, what's the message that you're translating to the public? And then 3, I'm going to share with you what historical data over the last 20 years looks like for that indicator. And I'm going to share US data and state data. All right, any questions about any of that? All right,
No.
so I'm going to start with gross state product. So gross state product is the state version of GDP, or gross domestic product. It's calculated almost the same way, but not quite the same way as GDP. And it looks at what's the value of goods and services produced by the state economy. And specifically, what's the change in the value of goods and services produced over time. So this tells us how fast the state economy is growing. We are right now going through a highly volatile time of state economic growth where it plummeted last year and it's spiking upwards this year, which is highly unusual to have so much change in 2 years, obviously due to the pandemic. If you were to tie the benchmark to gross state product, you would essentially be saying healthcare spending shouldn't be growing any faster than the broader economy. And oftentimes people talk about how the share of the economy that's represented by healthcare is too high or high and growing. That's a common reference point. People know X% of the economy is healthcare, and that percentage has grown my entire career. So you could be saying we want to arrest the percentage of, if you were to adopt this, we want to arrest the growth in the percentage of the economy that is healthcare based within the state. Here's some data that looks from 2020 back to 2000 on gross domestic product for Nevada, and then the federal one. So you'll see here that the state certainly follows the pattern of the nation. The state is in red and the US is in blue. Sometimes the state's doing better and sometimes it's doing worse over time. And you can see it's fairly volatile. The gray areas are recessions. You'll see right here the impact of the pandemic in 2020, where there was just a huge drop from about 5% positive growth to contraction of the economy in 2020. And the forecasts are for, on a national level, for growth at 8% for 2021. I will say in general, for all of these economic indicators, if you look at historical data, it tends to be volatile. All right, and we're going to talk about what that means for setting the value later on.
Michael, do you mind? We have one commissioner who has
Please,
a question.
at any time,
Okay?
please ask questions.
Great. Commissioner Bond?
Thank you, I appreciate it. I'm just trying to make sure I'm thinking about Nevada, where I've lived for 30 years, and what our domestic product really is, because our main industry is gaming. So I'm assuming that a lot of the gross domestic product in Nevada would be tied to how the gaming industry is doing on their profitability. But I might be getting that wrong. Can you clarify it for me?
Yeah, so this would reflect whatever drives the state economy. And so if gaming is a big portion of it, it certainly wouldn't be all of it, but it would have a major impact. And if that's so, Bobette, I would say it looks like, as the US economy goes, so goes the gaming economy. Because you can see there's pretty good correlation between what the state economic growth has been and what the federal or the national economic growth has been, not federal, national. There are examples where in some states where, extremely large portions of the economy move out of the state, and that has a negative impact on the state. So if the gaming industry ever left Nevada, that would show up dramatically here. But yes, you are right to think that any major industry is going to influence the shape of this graph.
Thank you.
And I just want to say, I invite all of you to ask questions at any point during my presentation, please. Whoops, I didn't mean to do that. I don't even know how I did that. I just took you to Fred. Let's see if I can get back. Nope. All right. So let me pause, and I'm going to bring back the presentation. Okay. So here we go. All right. So that's economic indicator option number one. Number two is personal income. So personal income is defined as earnings, wages, and salaries. It includes employee benefits, which is a big spending area, including healthcare benefits. So if we include personal income, we have a little bit of an interactive effect between the reference point and how we're using it. This certainly isn't all of what goes into personal income, but it's a portion of it. Property income and transfer payments. So these are both governmental transfer payments like Social Security, but it's also pensions and private transfer payments. Does not include capital gains. Okay, so this is more than just wages, but it's not all sources of income. And I'll note that capital gains are typically accrued to the benefit of higher income individuals. So by excluding that, we're a little bit more representative of the population, although certainly dividends and interests are also more often accrued by higher income individuals.
I've got a quick question before you move on.
Sure.
Other states done have other states used personal income?
So I'm going to review what all the other states have used. They are mixed in terms of what they used. The initial states, were sort of I should say the second and third states copied the first state. So they were copycats. Ever since then, there's been openness to a much broader array. And just last week, Washington said that, or at least some of the people in Washington said they wanted to consider personal income.
Thanks.
Yeah.
And Dr. Slonim has a question.
Yeah, thank you, Sarah. Michael, would expenses paid on behalf of individuals by government agencies, I'm thinking about that transfer payment line, example, Medicaid coverage, be included or not included?
Medicaid would not be included here. Yeah, the transfer payments here are really direct cash transfer payments,
Got it.
not services.
Yeah, so if somebody receives Medicaid benefits, or for that matter, Medicare benefits, that's not included in terms of adjusting the rate.
Yeah, I can't tell you why, but they only include employee benefits.
Okay, thank you.
Yeah. And so if you were to pick personal income, you would be saying that healthcare spending shouldn't grow any faster than the financial picture that consumers have, and it should match their financial well-being. Okay, that's different than the economy. This is sort of, the healthcare shouldn't take up a bigger piece of personal income for a household.
And that's because the growth of the economy is not matching the growth of personal income.
Right. They do not match. And I'll show you some data on that later. They don't match at the national level and at the state level.
Right.
Okay. There might have been points in time when they did match, Jessica, but they don't right now. So this is how personal income breaks out. Most of it is wages. Well, I shouldn't say most, only a little over half of it's wages. Transfer payments are a full quarter, and what's defined as property income is also almost a quarter. So when we're doing personal income, we're taking a more holistic look at the resources that come into a household. Right, we see the same choppy graph here that we saw before. What's really fascinating is you can see for 2020 that while the economy dove, personal income did not. And this is true across the United States. And this is, largely due to acts of Congress that distributed lots of money during the pandemic. Right, option 3 is a narrower construction of personal income. It looks at just wages and salaries. So those other two categories are not included here. And those other categories are categories of income that primarily accrue to higher income earners. So capital gains wasn't included in the other one either, but dividends, rents, interest, those usually go to higher income earners. Okay, and wages have been growing slower than personal income nationally, in part due to the growth in the value of health insurance benefits. So if you were to pick median wage, you would be saying healthcare spending shouldn't grow any faster than the median paycheck of a state resident. And I also want to know there's a difference between picking the median value and the mean value. And again, this goes back to what's been happening in the broader economy, both at the state level and the national level. So income has been growing faster for people with higher income than for people with lower income. So if you pick median wage growth, the value is probably going to be a little bit below what you would have if you picked mean wage growth, because you won't have the upward pull of the people with the highest income or highest wages in this case. Any questions about this?
But can I ask a question? This is Flo Con. Can I ask a question about, like, are there benefits to use of these different options individually? I mean, like, have you found that a particular option, has a greater benefit in a certain type of state?
I don't know that it varies by state. I think there are two implications, though, Flo, to answer your question. So one is they send different messages. Okay, and that's why we've emphasize on the slide what's the message. So saying we don't want healthcare spending to grow any faster than the economy is a different message than saying we don't want it to grow any faster than people's paychecks. Okay, that may or may not matter. It depends on how the commission and the state chooses to publicize what it's doing. But that can have an impact. In addition, the values are different. And I'm not showing you the values right now because I'd like you to think about this from a conceptual perspective, but I will share with you what the differences of the values are for both historical and forecasted perspectives. And some of these are going to yield higher values and some of them are going to yield lower values. So those are the two implications for your decision.
Can you clarify values?
Yeah, rates, percentages.
Oh, okay, right.
So some of these are
like,
growing faster and some of them are growing slower.
Right. So there'd be like a lower rate if we went for income versus the GDP of the state. Right.
Mm-hmm.
But I mean, I think the other thing is thinking about this still, even though we're sending this message, like we care about people's paychecks, the outcome could not like actually impact, because like you were saying, all of this actually may not even impact the out-of-pocket expense from the consumer.
So, right. So there's no guarantee, but it should. If you look at why consumers' out-of-pocket spending has been growing, it's because healthcare costs have been growing. And so what impact does that have on the consumer? Well, the premiums grow and benefit design changes to mitigate the premium growth. And so the deductibles get bigger and bigger and bigger and bigger.
Could I
So to the extent that healthcare spending doesn't grow as quickly, there'll be less growth in premiums and less pressure to continue to grow deductibles and coinsurance.
Okay, and I'm just trying to be clear on this. So if I could just drill down. So, but I understand that in theory. I think that's why everyone's excited about this. But in practice, evidence has not shown that. The states that have put this forward have not found that. And it could be that a lot of companies are just pocketing profits, or they're putting it on the, so I just want to put that out there because I think we're all here wanting the same thing for the consumer. So
yeah. And Jessica, I think it's totally a fair question. It's a complex dynamic because even if healthcare spending grows, you could still have individual consumers who, if they have a choice, could decide they want to go to a higher deductible plan, right? Despite the fact that healthcare spending has slowed. But you are right. And it's why in some states, they are beginning to separately track changes in out-of-pocket spending because they can't take it as a given. And if you slow total spending, that it's actually going to have a benefit on out-of-pocket spending.
Right.
Can we just get some backup on that, Michael? I'm sorry to interrupt without raising my hand correctly too. What Jessica's saying is that hasn't borne out in other states, that lowering spending doesn't, she's saying it doesn't lower out of pocket. Can we get information on that? Because I'd love to see whatever's making you say that's correct. It would be good. It'd be good to see what both of you are talking about.
Yeah. So what we know, you guys, you may or may not remember this, but what we do know is that commercial spending growth in Massachusetts every year was running above the national average until they created their benchmark. And then it began running significantly below the national average. Okay. So total spending for people who've got commercial coverage, be it fully insured or self-insured, dropped dramatically relative to the national average. The question then is, well, so what impact does that have on the consumer? Well, it certainly results in lower premium growth than what it would have been, which doesn't mean it's actually lower premiums. All we're saying is that it's growing more slowly. I mean, if we really wanted something aggressive, we would have a negative cost growth benchmark. All we're saying is it's growing more slowly. And in Massachusetts, it's correlation, not causation, but it's really strong correlation that says spending growth has slowed. So because premiums are set based on rates of spending growth, premiums in Massachusetts were lower than they would have been. There's a separate topic of, well, what about the out-of-pocket spending for coinsurance and deductibles? So that's complicated because it's influenced by the decisions that employers make on what benefit designs to offer. It's influenced by the choices that insurers make on what benefit designs to put into the market. And it's influenced by the decisions of individual consumers who, if they have a choice in benefit design, can decide that they want to increase, can decrease their premium. And that's what we don't know about. It's very hard to link causally what's going on there.
And Michael, if I can also just kind of point to one of the target initiatives, like project goals of this work, really is to provide the foundation to analyze spending data in an effort to kind of pinpoint cost drivers, and then seeing that and analyzing that will theoretically inform interventions or for consideration and policy. So there is also values in doing this benchmark to analyze the spending data.
Yeah, and then to take action. I mean, the whole part, as I've described in that logic model slide you might remember from before, the whole purpose for setting the benchmark is to then take data-informed action to address the cost drivers.
Right.
And certainly, if there's no action to slow healthcare spending and no action to address cost drivers, out-of-pocket spending is going to continue to grow at a crazy rate. So I would say, back to Jessica's question, while there's no guarantee that out-of-pocket spending growth will slow, there's probably a guarantee that it will continue to grow if you don't do anything.
I agree, but I would just say to Jessica's point, and I think it's a very good one, about there could be aspects of the healthcare system, which why the all claims payer database becomes so important. But there could be aspects of the healthcare system that aren't growing in terms of cost, but you wouldn't know that as a consumer because you're not getting any of the benefit. And we're seeing that a lot right now because cost sharing continues to go up for consumers, and there's very few policies that have been passing along the savings that have been accrued in the system to consumers.
But I would just like to challenge that a little bit, Flo. I understand what you're saying, but they may not be passing along savings, but what Michael's saying is it's reducing trend. Things are still all increasing. They're just increasing slower. There's not actually savings going into the system. There's a slowing of trend in the increase. There's not a decrease.
I think there could be. I think what he's saying is that you could see a slower decrease, but there are areas that are not growing in spending that look like they are, but they're not. And then in terms of the consumer, even when you've capped, so you can do all of this, you can cap costs, but if the consumer's still paying more, what's the benefit of capping that cost? And in fact, it could be doing more harm to the system overall. So I think you have to be careful in how first of all, you got to make sure you have the correct data, which is what I think we're trying to do with the all payer claims database, and making sure you have the right data. And then what you're trying to do is ensure, as Michael said, you want to limit, and certainly by having transparency on the process and knowing where those cost drivers are, you can certainly start address and targeting where you need to make changes in your policy. But at the same point, I think just having the information, we need to make sure that whatever we're doing is bringing down the cost to consumer. We're not just cost shifting, which is what's happening today. Because yes, we could hold the premium here, but if all you're doing is holding the premium here and then increasing your cost sharing over here, you're not helping the patient or the consumer. I should say.
Well,
So I think it's
I agree with
appropriate
that.
for you as a body to talk later on about, okay, so we set a benchmark. Now, what steps can we take to both get transparency in terms of the impact on the consumer? And are there other steps that we could take to make sure that consumers benefit?
Yeah,
Yeah,
and I
that's-
think that's all I
that's-
wanted was to just keep that on the table. Like, this is great, we're doing this, but then also be like, that's interesting, this hasn't, not that it hasn't worked in other states, but what else could we look at or do to work on that?
Yeah. I totally agree.
Me too.
Okay, so this slide just shows variation in median wage. This difference between Carson City and the Las Vegas metropolitan area is 18%. And the reason that I share this is while we talk about setting a benchmark and aspiring to keep healthcare spending growth on a per capita level to something below what it has been, any growth is going to be experienced differently by people depending upon what their wages are. And if your wages are higher, then an increase will be experienced as less difficult than if your wages are lower. So that's the only point I want to make here.
Like a quick comment. Are any other commissioners, and maybe I'm just surprised myself, are any other commissioners surprised by the finding that the non-metropolitan, I read that as inclusive of rurals, is as high as it is to the metropolitan areas? That strikes me as being an interesting finding.
Yeah, I agree, Tony. It is, you would think you would see a little bit more disparity as far as the swing in incomes, especially some of the concentration of higher earners in some of those cities. But yeah, it's looks too close to me.
Yeah.
I'll say that I am surprised, but in my mind, I kind of work it out that it is probably related to the fact that there are a large number of low-wage jobs, fast food servers, hospitality, stuff like that in the large areas. And you do have mining in the outside areas. So the per capita income is going to be higher probably for those workers.
Would also some of those other communities, a little bit more rural, have a little bit more of a fixed income, maybe Social Security or pension based, obviously more land property. Obviously, I think if we adjusted this per population and size, we probably see a little bit difference, but maybe that's driving it too. But I agree, Justin, too. Mining's got a big part of it.
Commissioner Bohannon has a question.
I don't have a question. I just have a comment on this. And I think that I can't really speak to Las Vegas area, but I can speak to Reno. And what I think that Slonim is pointing out is that that's a pretty significant disparity when you then factor in the price of housing here. And we have a lot of people that own second homes here. So while you see a lot of wealth in this community, there are a lot of people that don't necessarily work here. And we have a lot of people also that work in California, at least here. So I think that looking at medium wage is a little bit blinding.
Now, again, if you were to use median wage growth, you'd be using it at the state level and you'd be looking at change over time.
Okay.
So here's a graph.
Go ahead.
Okay, so here's a historical graph again. We've got about 20 years of data, and you can see, as with everything else, the state and national rates sort of weave with no consistency. There's a strange effect here in 2020, and I think this reflects the fact that during 2020, the low income jobs disappeared. We know that people with low income jobs were most harmed during the pandemic. And I think that shows up here in terms of the change in wages. Because the people who lost work dropped out. And by the way, I haven't said this before, but all these graphs use nominal values. That means these are non-inflation adjusted rates. And the reason for that is the benchmark is going to be nominal. So if you're going to use any of these indicators, you want to also be using nominal values.
Michael, just to expand on Tony's and Teresa's point on the population and some of the locations in the state of Nevada, I'm sure at some point we're going to layer in Medicaid populations in those communities. And I think we would kind of see both Tony's and Teresa's point of higher Medicaid populations, some of those denser, lower paying jobs, parts of the economy.
Yeah. Yeah, and in the rural areas, you may also have some just small number artifacts because the populations aren't that large. It might be a little deceiving. Okay, the fourth and final option is inflation. And inflation looks at the impact of rising prices, which decreases the buying power that consumers have. There are multiple inflation indices. The most common one is the Consumer Price Index. There are multiple versions of the Consumer Price Index. So the one I want to put before you today is the all urban, which is a bit of a misnomer because it captures the experience of 94% of Americans. This is looking at changes in prices for a market basket of retail goods and services that consumers purchase. So it's not the prices of everything. It's not the prices in the whole economy. It's just for retail goods and services. This provides a very consumer level perspective because consumers track how much the change of the price of gas or milk is over time. And so if you were to pick inflation, you would be saying the cost of healthcare shouldn't grow any faster than the other prices that consumers pay. So I want to pause a bit on this. So healthcare spending obviously isn't just price, right? It's the result of changes in price and changes in service volume and changes in service intensity. From the consumer's perspective, however, healthcare can be viewed as a price. It's the price of a premium, or it's the price of a service that you pay out of pocket. So while an economist might say healthcare spending isn't a price, through a consumer lens, it can be viewed as a price. And this is, again, another volatile graph. You'll note that up until just the last couple of years, the only data that we had that included the state was for a broadly defined Western region. As of 2019, there's a mountain division, and so this blue line is that new mountain definition, which is where the state falls.
I just have a question on this option in terms of the stability and uniformity of like CPI, because I understood CPI changes pretty dramatic. I mean, I shouldn't say dramatically, but there can be significant changes over a short period of time. So how does that work in terms of the goals of looking at trying to get a stable, uniform, kind of maybe more targeted, if you will?
Great question. Thank you for asking it. So we're going to talk about that shortly. You've got a couple of options, in terms of how to use these data. One is to say, we're going to look at a multi-year average. And if you're going to do that, you probably want to look at a long time period because you want to be able to account for the ups and downs. If you picked only 5 years, you would get a much more distorted view than if you picked 20 years. So that's one option, Flo. The other option is to use forecasted values. And forecasted values, especially if you look at long-term forecasted values, tend to be very stable. So those are your two options, and how you address the inevitable volatility that's going to occur.
Thank you.
Okay, so I want to pivot now to comparing these options and then asking you to weigh in on what you think makes sense. So, oh, actually, it says I presented 5 options. I didn't. I only presented 4. So I apologize for that. So let's talk about the pros and cons for each one so that you can decide whether you think any of them are better or worse of an option for using to inform your benchmark value. Okay, we're starting this on a theoretical basis and purposefully not giving you, here's what the value would be if you pick this indicator. Okay. So you might ask, well, how can we make a decision on meeting the third criterion, which is lowering healthcare spending if you don't know the value? I will share with you later on what healthcare spending growth has been historically for Medicare, Medicaid, and commercial. So you will have some sense of what it's been. All right, and that will help you judge whether that third criterion would be met through the adoption of one or more of these indicators. Okay, and I also want to note, while you will be considering these indicators and the values as they are, you also have the option of adjusting them. So you could say, well, we like median wage, but we want to add or subtract 1% from it. That's a choice that you can take if you want to do so. So a quick reminder of what the other states have done. So Massachusetts was the first state. They had legislation in 2012 that dictated that they had to use potential gross state product. Potential gross state product is forecasted state GDP or GSP, right? Forecasts of what economic growth will be, and it's the long-term forecast. So it's for years 5 through 10 into the future. And it gives you a very stable rate. So that's what they did. It was in their legislation, so they had no choice. Delaware and Rhode Island were the 2 states that followed, and they essentially said, let's copy Massachusetts. The copying activity changed, though, when Oregon worked on this. Oregon went in a big different direction. First, they said, we don't want to use a forecast, we want to use historical data. So we're going to use historical gross state product, but we're not just using one indicator, we also want to use historical median wage data. And on top of that, we happen to have a Medicaid waiver program that has built into it a per capita growth cap. And our legislature liked that per capita growth cap so much that they put it into legislation that our state employee health benefit program couldn't grow any faster than the same growth cap that we have in our Medicaid waiver. So in Oregon, their parallel body to the PPC looked at all of these considerations and didn't specifically tie to any one, but they picked 2 different values, one for the first 5 years, one for the second 5 years, that were informed by all of these values. That's a different approach. Another approach is what Connecticut did. So Connecticut came after Oregon, and they decided they wanted to pick 2 indicators and they wanted to do a weighted blend. So their approach is 20% potential gross state product. Again, that's the forecasted economic growth, and 80% forecasted median income. So these are very different approaches. You are not obligated to follow any of them, but I just want to give you some context for what others have decided to do. Any questions about the approaches in these 5 states? I know I shared this before, but now you probably have a better sense of what this means.
Anybody raising their hand or wanting to say something? If
Yes,
not,
Commissioner Bond.
Go ahead. Yeah, go ahead, please.
Bond? I thought you said Bohannon. Okay. Can you just quickly say which ones are prospective and which ones are retrospective again? I see Connecticut is forecasted. And
Yeah. So there, Oregon is the only state that used historical values. All the others have used forecasted values.
okay, thank you.
And it's sort of funny how they got there, I will say as an aside. So one of the members of the advisory body in Oregon is the state economist. And of course, economists spend lots of times working with forecasts, but at one of their meetings, he said forecasts are unreliable. So because the state economist said that, that tipped the group to using the historical data. Any other questions?
Commissioner Flood.
Thank you. Is there any real significant difference between these numbers? It seems like everything's in the 3% range. Am I wrong?
So there are differences. You are right. The states that have set their cost growth benchmarks to date run between 2.9 and 3 point, I don't know, something percent, high threes. So generally people are winding up within the same spread, but there is a difference among these indicators. For example, inflation is markedly lower than state economic growth. Depending upon whether you use historical or forecasted, you're going to get different numbers. And if you're using historical, whether you're using 5 years or 10 years or 20 years, that's going to yield different numbers. And you know, while it feels like it's just 1 or 2 or 3 percentage points, that's really a lot of spending.
Trajectory, yeah.
It's a lot of spending.
So, and I just want to throw it out there because we're trying to create some rationale, but it's a little arbitrary is kind of what you're saying, but really it has to do with the philosophy of the commission. And do we want to be more aggressive in trying to tamp it down or less, and then balance that with like also, to Commissioner Sloanham's point, supporting our healthcare in the state, et cetera. Right?
Yeah.
Okay.
Yeah. There's no formula for doing this, and this isn't easy. All right, so here are the indicators we've talked about.
Sorry, Dr. Sloanham?
Thank
No,
you.
go ahead.
I want to echo Commissioner Flood's point. I think this seems to me a little bit like standard setting in a test, almost, right? Where you have to identify the passing score. And there's a lot of art to that, not as much science, but a lot of art. And it makes me wonder about the decision that Oregon made to be multidimensional in their approach. Any more depth of insight there? Because classification error in each of these separate approaches, these methodologies, can matter, I think. And so maybe there's an insight that they had about not picking one, but combining. Any more thought on that? Or maybe,
yeah, their process was a lot of messy swirling, to be honest. Ultimately, because they already had their Medicaid target and their state employee target, they decided to start there. But there was a lot of pushback from the employer representatives and the consumer representatives who felt that given historical and forecasted wage growth, that it was too high because it was above wage growth. And so what they negotiated was that they would start with a higher rate and then drop it down by almost half a percentage point so that over the longer time period, healthcare spending wasn't going to grow faster than wages. That was their particular debate. And you know, where people wind up, it has a lot to do with who's in the room, who sits on a body like this commission, and what voices speak up and how they negotiate it out.
Thank you.
I've got Barron and then Bohannon.
Thanks, Sarah. So two thoughts came to my mind as I'm listening. One is, and maybe Michael can speak to this. What is another factor here is what is the reliability of the data for Nevada across all of these different potential measures or approaches? In other words, is the reliability of the data on median wage better than or more accurate for Nevada than the reliability of gross state product or potential gross state product, et cetera? And do we have access to that information in terms of making a decision? So I was just wondering if you could comment on that, Michael.
Mm-hmm. Well, so the historical data, it is what it is. I think you should feel pretty good about the historical data. The question is the forecast, and it's inevitable the forecast is going to be wrong. So if you're going to, right, because you've seen the volatility for all these measures, and the forecasts are going to give you a straight line, especially if you use years 5 through 10 out, and it won't be a straight line. But the forecast allows you to pick a value that you can say, well, if we think that the economy or wages or income are going to grow at about that level, then that's a reasonable basis for setting where we want our benchmark to be. But you can be assured that the forecast will not ring true exactly.
Okay, thank you. And then my other question is that how many of these states that you have listed on the slide had an all payer claims database such that they could kind of have a sense before they went into this methodology as to where the costs really lie in their healthcare systems within their states? Because we don't have that advantage right now.
Yeah. So all but Delaware had all payer claims databases, but none of them used analysis of their all payer claims database to set their benchmark value. And I would argue you don't need to know that information to set your benchmark. You do need information to figure out what's driving healthcare spending and what actions need to be taken to achieve the benchmark, but you don't need it to set the benchmark value. What you really need to set the benchmark value is an understanding of how fast has per capita healthcare spending been growing, and where might you set a future benchmark value that's below that, and which seems linked to some consideration that's meaningful. That's all you're doing now.
Right. And it makes sense to kind of be like, reasonably, we should have it below the GDP, right? Or around there, because we don't want it to grow above the GDP. That was
no state has set
or not below the GDP, but like around there, right? Because they're like, well, I don't know.
Right.
Bohannon.
Thank you. I agree with the state of Oregon not to rely on forecasting, because my experience with forecasting is that they're only as good as the assumptions and data available to them, and they're often wrong. So I kind of see why they would land on using historical data. That being said, I guess I'm wanting to back up a little bit and understand the process. So you're giving us this information now sort of as a presentation, but it's ultimately going to be the advisory subcommittee that we all just agreed upon that's going to do this work and present it back to us.
No. No, this is your recommendation to make. The advisory subcommittee will only serve as a sounding board. So we will bring to the advisory subcommittee a condensed version of this information, and we will tell them what you have developed as a preliminary recommendation, and we'll ask them to react to it. And then we'll bring you their reaction. Does that help?
Yes.
Any other comments, Sarah?
I don't see any.
Okay, all right. So this table provides some of the advantages and disadvantages of these indicators. So I just want to review them with you. Gross state product, whether it's historical or forecasted, it's used by most other states, at least in part. And you might say, hey, we like doing something consistent with a bunch of the other states. The disadvantage is it's sort of an abstract concept for the public. And so to the extent it's important to you that you can convey to the public how you set the benchmark, and that may not be important, but if it is, it doesn't work, quite as well. Personal income, and I would say median wage, these are both consumer oriented. Personal income looks more broadly at income, and median wage really just looks at the paycheck, so to speak. Personal income grows faster, or it has grown faster than wages, because it includes higher earner non-wage income, and that's not the case for median wage. Okay, and then finally, inflation. It treats healthcare as a consumer household, it says expense, really price, which is what consumers do. But healthcare spending really is driven by both price and volume. Okay, so that's just an overview of the ones that we've talked about. So I'd like to pause now and ask you, based on what you've seen so far, do you have any preferences for these four indicators? And again, if there's something else that you think we might consider as an alternative, you have the opportunity to introduce that. I'm not asking you to make a decision, but just want to ask you to weigh in on whether any of these resonate more or less for you.
So maybe we can go in the order so every commissioner has an opportunity to give their views. Sarah, could we go in that order, please?
Sure. I think we should start if commissioners can raise their hand instead of doing the round table. I'm not sure everyone wants to weigh in.
Okay, sounds good.
Okay, let's start with Dr. Barron.
So just in thinking about this, I'm not sure about inflation as a measure, simply because inflation, the Federal Reserve can make a change in interest rates or what have you, and inflation can be adversely affected simply by that. And to me, inflation, it's important probably not to grow faster than inflation, but I'm not sure that we have really much control over that volatility. With regard to comparing personal income versus median wage, I'm not as concerned with people who get dividends and things like that. I think that those are not the people that are having trouble affording their health care and their health care premiums. I think it's the people that are included exclusively in the median wage group that I think we're more concerned about in terms of patient protection. And so if I had to choose one between personal income and median wage, for me, median wage makes more sense, just simply because it captures the population that we're most concerned about. Gross state product, I think, could be used as well, although I agree with Michael's previous slide, which is that it's an abstract policy, and I'm not sure how most citizens would react to that. That there's certainly in the past year and a half, there's been times where the state wasn't doing well, but as his graph shows, the personal income grew, and conversely, there's a median wage slide showed a steep upward trend in median wage, but did not take into account anything having to do with our extremely high rate of unemployment in the last 18 months. So that could be somewhat misleading. So I can see the pitfalls of all of these things. I guess for me, gross state product and median wage stand out to be my favorites in this list. Thank you.
Thanks. I just want to add one thing before we go on to the next person. And thank you, Howard. I want to note that while there's volatility from year to year, if you're using any of these indicators, you're not literally linking to them on an annual basis. you're going to be using a multi-year historical look back, or you're going to be using a multi-year forecast. So there will be strange things that happen, as they did during the pandemic, where we saw average or median wage go up, which made no sense. Just know that's not going to be a distortion that you are going to experience if you pick any of these, because you're using multi-year look back or multi-year forecast.
And just so for clarity, everyone, I'm going to be calling on Dr. Slonim, Commissioner Van Houweling, Commissioner Bond, Commissioner Flo Khan, Commissioner Roa Dugan, and then finally Commissioner Flood. So in that order. Dr. Slonim?
Yes, thank you. This has been a great discussion. I really appreciate it. It seems to me, based on, I agree with everything that Howard said, actually, and the same reasons. I'm leaning more towards gross state product for a couple of reasons. One, I like the fact that it's a more local measure that accounts for nuances in the state that may not be represented by other measures more broadly. Second, I like the fact that there's a precedent for other people who have done this, a bunch of smart, other groups of smart people who have gotten together to think about this intently and what it means. And I think that there's some value there, while acknowledging the risks that I think is very helpful. For me, again, this comes back to the big and audacious ask, which is, when you're standard setting, you want to make sure that you're identifying your biases and incorporating a measure that represents the broadest and most local context that you can, for me. And that is Nevadans, urban, rural, here, there, all income levels, high quality, high wage earners, low wage earners. And I think, for me at least, to the degree I understand it, the gross state product does that better than most. Thank you.
Okay. Commissioner Van Houweling?
I think Dr. Barron and Dr. Slonim kind of took the words out of my mouth. I think as I'm looking at these, wages are certainly a better indication of what people are living on paycheck to paycheck. As Dr. Barron eloquently stated, we're not so much concerned about dividends and other passive income that may be coming in. It's probably a better reflection on what we're trying to tackle. And then I was leaning also to gross state product, but I'd like to hear a little bit more conversation. But I think those are the two top priorities, and but still wages and paycheck is probably our best indicator for us to make decisions on and make the most impact for our state. But I'll continue to listen on the other ones as well.
Commissioner Bond?
I also want to just say thank you. It's a really excellent presentation. I don't feel educated enough to make a decision today. So when you say, which way are you leaning, this I'm taking that to heart, okay? What I would like to rule out is personal income for all the reasons everybody else stated. I think median wage needs to be in this formula. And I think in Nevada, there's so many people that are low income that is not necessarily the same life that, you know, people in Connecticut live. So I really appreciate the conversation about median wage. So I would say that I would lean towards median wage being paired with gross state product or inflation, but I feel like I just need to learn more about those two. And I don't feel like I'm educated enough today, though I appreciate all this so far. So I would just rule out personal income and then marry median wage with one of the other factors, depending on what goes into those factors.
Okay. Commissioner Flo Khan?
Thank you. Yes, I agree with a lot of what has been said. I think I would just go along with gross state product for many of the reasons that Commissioner Slonim said. So if I had to choose today, I would definitely go with gross state product. Thank you.
Okay, thank you. Commissioner Roa Dugan?
Okay, thank you so much for the presentation. So it's a lot of information and a lot of things that we still have to think about. But I'm leaning towards wages and salary, so paychecks, and taking into account that this commission is here to protect the patients, especially the most vulnerable. I think that would be the best option. But I'm open to the idea, like Bobette said, to add either the GSP or inflation. But definitely wages would be my main option.
Thank you. Commissioner Flood?
Thank you. So I feel the same as many of the commissioners. I'm torn between gross state product and medium wage. I agree with what the prior commissioner said, Roa Dugan, in that, like, we're the Patient Protection Commission, and it would send this message that we're, for the people. But I also really like what Commissioner Slonim said about the gross state product, that there is precedent on that, and so it makes sense in that regard. I would love it if we could see the numbers side by side on what that percentage is, just so that we could kind of compare them.
We will soon.
Great. I don't have any other commissioners who are seeking to speak.
Okay, so we can move on. Do you have any more presentation?
But I do have Dr. Slonim who'd like to just take a moment. Dr. Slonim?
Just one more quick comment. It strikes me again that we're, make sure I get this right, Michael. Because we're setting a standard, it's not just about patients. It's not just about the people who are receiving the medication, getting illness care, because you never know tomorrow or next week or 6 months from now who's going to be a patient who formerly was just a person, right? So it's bigger. This is a bigger conversation than just patients. This is about preventive care. This is about access. This is about all of those services that you could put in a bucket to make sure people get ample preventive care, mental hygiene, all the rest of it, it seems. Is that accurate?
This is to capture all spending for whatever the spending's for.
Okay.
It's totally inclusive.
Got it.
Yeah, and as I suggested, earlier, there can be a separate conversation about resource allocation and where the dollars go. Not for today, but that's a valid conversation.
Yeah, the reason I bring it up is because it is inclusive, right? If we focus on patients in our analysis or in our conversation point about which measure, then that captures, we know that healthcare is not a normal good, right? It's not like the price, like the price of a gallon of milk. And so understanding for those of us that may be healthy and not consuming a lot of healthcare, but 6 months from now develop a cancer, there's a difference in that mind shift. And as I'm relating it back to the question on the table, seems to me another reason to get out of the personal level of it and to the broader level. This is, I think Sarah mentioned this point up front. This ultimately will lead to policy decisions, right? This ultimately will advance. So it is incumbent on us, I think, as commissioners to make sure we're looking at the broad perspective on this. That's the only point.
Thank you. I have 3 commissioners with their hands up in order. We'll go with Flood, Bohannon, and then Bond. Commissioner Flood?
Great, thanks. So something that when Commissioner Slonim speaks, I hear it and I wonder so there is this concern, is our healthcare in Nevada, has it been starved historically? We're like 51st in the nation for mental health and whatever, so many other things. And sometimes when he speaks, I think about, like, if you think about the starting line, are we behind a lot of states? And so I get that concern of not wanting to, like, continue to kind of tamper down the healthcare industry. So to that regard, I just wonder, comparatively, compared to other states, have we looked at per capita healthcare spending in our state versus other states? I just would love to like get an idea of where we're at to understand.
Sure. We can do that we haven't, but we could do that for the next meeting and share that with you.
Do you think that'd be helpful?
Well, it sounds like it would be helpful to you, so.
Well, just to understand, I don't even know. It's just like, we're like, oh, everyone else is trying to, and I understand the need to like slow down the healthcare costs, maybe, period. I'm just trying to orient, that's all. Thanks.
Yeah, we can do that for the next meeting.
Hannon, thank you.
Thank you. I appreciate Commissioner Flood's comment. I think one thing to keep in mind when you look at any sort of historical healthcare spending in the state, and back to Dr. Sloan's point, that we are behind. A lot of that has to do with the lack of public health spending in the state. So that has a lot to do with why we're 51st. So I think while I think it would be a very useful metric to explore, it might be a little misleading because we could either be overspending or underspending. That might not necessarily be reflective of where we should be spending either. But the reason I raised my hand was we had discussed with our subcommittee makeup that we would try to find a health economist. And did we land on anyone? Because I'm looking at this and I feel like this is really a conversation with a health economist. I'm not an economist, that's not my training. I work with economists and I know that this stuff can get very complicated. And so I am curious if we included anyone like that. And if we haven't, if we might want to think about reaching out to somebody who is an expert in our state or even maybe nationally, who could weigh in a little bit to answer some of these nuanced questions.
So I can speak to that and just point and remind the commission that Mr. Vance Farrow was added to the list. And although he's not directly a healthcare economist, and you are right that perhaps if you have some recommendations for someone that in the state, it could be valuable. But Mr. Farrow is the healthcare industry specialist at Nevada's governor's economic development office. And so I think he will be helpful in his perspective, but if you have any other recommendations, please connect with me.
Can I add something, Sarah?
Yeah, absolutely.
So some of the other states have had economists sit on a body like this one, Massachusetts, Oregon, Connecticut. It was helpful to have them there to explain some of the technical details of these economic indicators, but the eventual decision of which one to use wasn't really a decision for an economist. So I just wanted
But they did add perspective and they helped from a technical standpoint to understand a little bit better about
the indicators.
Yeah,
Yes.
and I think that's what I'm hearing maybe from some other commissioners, that it might be nice to at least just have their perspective and maybe be able to walk us through some of the differences in what this is. Because I don't know that anyone on our commission is actually an economist. Not to say you have to be one, but I do think it helps to have that kind of perspective.
All right, if we have anybody else so that we can move along.
Yeah, we have Commissioner Bond.
Okay.
Thank you. I would like to make sure we understand as we move forward. I'm listening to Dr. Sloan talk, and he's saying that our health economy, our healthcare sector is not a normal market, and it's not, right? But I think we see it from opposite perspectives. So I think he's saying that we don't know the price. We know people end up knowing the price. What we don't know is the cost. And I think a lot of work that we've gone into on transparency in this state is starting to lead that direction. I think we don't have everything we need yet, but I'm hoping the commission will always support getting there. But to that goal, I think there's a difference in what goes on with spending, which I hear Commissioner Bohannon talk about, and Commissioner Flood a little bit, in the public sector versus the private sector. And I don't know if anything that we're doing is going to help us get oriented about both of those, pricing isn't designed by the people that pay for it, right? Pricing is designed by the people that provide it. And how do we separate those out in these conversations to understand there's this big weight on all of us about the concern about Medicaid funding, and it comes up in every meeting. There's a big weight on us about the concern of what the private sector is having to pay for care, and it comes up every meeting. And so I don't know if we're going to capture that in these larger conversations. Maybe it's a different group that has to see that, or maybe it's a different meeting, like the quality issues, you know, or the underspending issues. But how do we balance that? The private sector and the public sector are living different lives in resources.
And they're both resource constrained.
Yeah.
Right.
And they both are. So
Yeah.
I'm hoping that we're catching all that as the prices go up.
Okay, I don't have any other commissioners' hands up. Oh, sorry, Dr. Slonim.
Thank you, Sarah. Michael, do we have any, I'll call it, measure of sensitivity between the measures, right? So given what the underpinnings of each benchmark are, there may be things that are more sensitive or less sensitive to the creation of the measure. I'm really hung up on the issue of standard setting and benchmarking here, right? So usually you have sensitivity metrics, you have reliability metrics, as Dr. Barron mentioned before. You have other performance estimates around the measure that help to inform what's a better measure of the benchmark than others. Anything like that exists?
Not that I know of, but I'm also not sure you need it. And ultimately, what you are all doing is picking a number and saying, we want to aspire to having per capita healthcare spending growth in our state not grow any faster than this. This conversation is about what should be our rationale for picking that number. So I wouldn't get too caught up in these individual indicators. They are all very, very commonly used and accepted economic measures. And in the end, you're trying to come to agreement that when you pick a number, you're picking the number because it is in relation to some indicator that you think has value and conveys an important message.
And yeah, I hear you. Thank you for that. That's helpful because it's the consistency over time that matters. It's pick an indicator and it's the consistency over time that you're benchmarking against. There's a part of me that I don't intend this comment to be flippant, but it resonates with me about some of the other comments that commissioners have made, which is, this has been a great dialogue, is, does it matter? Given what you just said, does it matter which one? Because it's about consistency over a long protracted period of time, not today and next month. It's about one measure that you're following as the standard. And so we're conversing and debating and challenging ourselves. And I'm actually asking myself the question, maybe because I don't know enough, does it matter if you pick one or the other, you know?
Yeah, so to some extent, no, but I think that when you're picking a value, I think that you being able to explain the value and how you reached it, I think there's some value in that. But you're not wrong, Tony.
Bohannon?
Thank you, Sarah. I really liked Dr. Sloanum's point, but I feel like Commissioner Flood had asked, like, is it possible to maybe kind of have these all charted out? Because I feel like if I had a table that showed what these numbers are and what they would be and like what it would translate to, I feel like I would make a better decision. I almost feel like it's like pick door number 1, 2, 3, or 4, and then we'll unveil what it's going to be. And so I don't feel like I can make an informed decision because everybody was convincing me that median wage makes sense. But then as Michael was speaking about it, then I thought maybe they should be tied to inflation because there could be a lot of volatility in the coming years, especially with COVID impacting healthcare spending. So I don't feel like I'm making an informed decision.
Yeah, Teresa, that's fair. And you might recall at the outset, I just asked you where you were leaning, not to make a decision. I'm going to share those values with you. I think this conversation that we've had has been productive, and I don't think we need to push it any further. What I've heard from all of you is that while you differ from person to person, you generally have interest in gross state product and median wage. Some of you would like a combination of the two, or you haven't decided which of the two, and some of you like one. But I think you're largely leaning towards two, and that's all we need to know for now. Okay, we're gonna talk. I've got some more slides to share, and then I will share the values with you, and your perspectives may change them. Okay, but I think for now, we've gone a long way, and in fact, I know that our schedule was thrown because the first agenda item took a little time. I'm wondering if this might be a good time to pause and take a break, and then we can do the rest.
So,
You read my mind.
Sarah,
I was just going to ask that.
how are we doing with time allocation?
So you are a little bit ahead of schedule, and as Mr.
Okay.
Bailitt pointed out, you're kind of just over your halfway mark in the presentation. So if it's desired by you and the commission, perhaps taking the 10-minute break is where you guys would like to be before you go into the second half.
If nobody has objection, we could do it.
Okay, does anyone have an objection to that? If you can, just please raise your hand and I'll see it. I don't see any objection to a
Okay,
break.
so we'll reconvene at 9:51.
Okay, great. Thank you so much.
Thank you. All right, we should be back. Sarah, are you there? Hello, Sarah? Sarah, are you back? Is everybody back online?
Like everybody.
I'm here.
If everyone can just turn on their camera so I can just make sure that you are indeed present. You're okay.
I think we'll proceed if everybody is back.
I think we are okay for you to go ahead and call the meeting back to order.
Yeah, so I think we can proceed, and if Sarah is tied up, she can join shortly. So can we catch up from where we left?
Chair Khan,
Yes.
Sarah's there, but she's on mute.
Okay.
Sorry, it is just me, my AirPod. Sorry, guys, Zoom world technical difficulties.
No problem. So we restarting, catching up from where we left.
Yes, so it'll be, Mr. Baylett, are you ready to pick back up? All
I'm
right,
ready.
we're good to go. Thanks so much.
Okay, so you all are eager to see some actual values. Before we go there, I want to have a brief discussion of using historical versus forecast values. And then we'll talk about potential benchmark values. So there are two options on how to calculate an economic indicator. So we just discussed historical experience and a forecasted projection. I just want to look at the two options. So historical experience, you have to pick a time period, 5, 10, or 20 years. In the graphs that I showed you, it was about 20 years when that was available. The longer the time period, the less the calculation is going to be subject to year-over-year fluctuations. It is very simple to calculate a historical value for any of these economic indicators. Easy to do, no problem. Forecasts are a different story. Forecasts can be obtained through two sources. The government and sometimes both federal and state government will do forecasts. And then there are private businesses that do forecasting, and Moody's and IHS Markit are the two biggest ones, to my knowledge, that states use. So states will often contract with one or the other of these to get forecasts to help inform state tax revenue policy and all sorts of other things. The methodologies used by government are transparent. Those used by private forecasting firms, less so. So the downside of using those private firms is it's a little bit of a black box to know how they come up with the values that they have. When we look at historical versus forecasted values, whoops, sorry, didn't mean to do that. Looking at historical values, as we've seen before, they're volatile. If you look at forecasted values, and this is real information, so you can see big drop in the GDP to a negative growth rate and forecast at about 8% for 2021. What you normally see in forecasts is they can be a little bit bumpy for the first few years and then they level out. And that's why a lot of states, when they're using forecasts for GSP, are using forecasts for year 5 throughout because they're flat for year 5 throughout. The forecasts for the near term tend to be a little bit more volatile. So 4 states are using forecasted measures. As we've talked about, Delaware, Massachusetts, Rhode Island are all using potential gross state product. Connecticut is using it in part, but all forecasted values. So I want to explain a little bit about Pgsp just because so many states are using it. So it's looking at the long-term average rate of growth of the economy. As I said before, it's years 5 through 10, and it's calculated per capita. This is the only economic indicator that has a publicly available forecasted calculation. It's not exactly the same as gross state product, but it certainly is similar. It is easy to calculate using publicly available information. So this diagram shows you how Pgsp is calculated. Those are the orange boxes. That's what the 4 states are using. It's a combination of state level indicators and some national ones. Again, simple to calculate. On the left, we see GSP, it's calculated differently. And so I just want to call out that contrast. So if we're doing a historical measurement of gross domestic product growth, it's not the exact same calculation as the forecast. So the respective advantages and disadvantages of historical and forecasted. So historical, easy to calculate. It reflects the truth. It's what happened. Disadvantage is there are always economic booms and busts, and so you're going to get different results depending upon the time period you pick, and there's no objective rationale for that time period. The forecast smooths out the historical variability and provides some stability and predictability, but these are predictions and they're bound to be incorrect. And the longer term forecasts used by private forecasting organizations have methodologies that are unknown to us. I will note, which I didn't state earlier, that if you use historical values, you can use a simple flat average calculation or a median calculation. There are also techniques for smoothing historical data so that you take out some of the peaks and the valleys. None of the states have used such technique, but that is not an uncommon approach to take to using historical economic data. So to date, as I think you've noted, Oregon's the only state that's using historical values. The rest are using forecasted values. Washington, as I indicated earlier, is just talking about this, so they haven't made a decision yet. And New Jersey will be talking about it in the next couple of months. All right, so before we talk about any actual values, do people have thoughts on whether there are any inherent benefits to using historical versus forecasted values?
Hey, commissioners, I don't see anybody's hand raised. If you can do that virtually for me. Okay, yep. All right, we are going to start with Bohannon and then go to Barron.
I like the idea of using historical data and smoothing out for some of the economic events that have occurred in Nevada. I mean, obviously, we've been one of the hardest hit states, like with the last economic recession, with so many people that went unemployed, with the shutdowns and everything that's happened with the pandemic. So I do think that that would have to be accounted for, but I'm just very leery of forecasted values. And that has to do more with my professional experience, but that's just my 2 cents.
Thanks.
Thank you. So we're going to go to Barron and then Flood. Barron?
Yeah, I agree with what Commissioner Bohannon just said. I'm leery about the forecasted information, in part because of the opacity, as Michael put it, of the how the data is gathered. And also the factoring in things like, projected labor force increases and things like that. I mean, that's really hard in a kind of a company town or company state like Nevada, where as Commissioner Bond mentioned earlier, is very heavily dependent upon how gaming swings one way or the other. And you can have projections because 2 new large resorts are opening with 10,000 new jobs, but then they quickly go away within 6 months and things like that. And so I think we have a volatility in our market that's because it's so dependent upon one industry that would make forecasting a little bit difficult. And so I would agree with the historical aspect.
Thank you. I'm going to call on Flood, and then Commissioner Van Houweling, and then Commissioner Bond. So Commissioner Flood?
Yeah, I agree with both of the prior commissioner statements.
Okay, thank you. Commissioner Van Houweling?
I think obviously forecasting is a challenge, but also historical. We just need to factor in some of the, and I think we've all lived through the recession, but more recently the pandemic, which has really skewed our healthcare costs related to acuity, length of stay, unemployment, obviously the second highest unemployment in the country behind Hawaii. So I think we'll just have to have those footnotes when we look at historical data, when we look at costs and expenditures and budgeting and those type of things. But just knowing that going into it on the historical data that Las Vegas and Nevada and Reno have always experienced bigger swings when the national economies struggled.
Thank you. So I've got Commissioner Bond, and then I'll go to Commissioner Flocon. Commissioner Bond?
I think what you showed earlier, I'm trying to find the older slides, is that most of the states are using forecasting. And I think that we should be forward thinking. So I think there's probably a way to use our trends, our actual trends, to create our future, kind of like the Economic Forum does, and takes into consideration how the industry's moved over time, if that's going to be a key factor. Personal incomes, we're not using personal income. If we use median income, I feel like the same. I mean, people make projections to the future. So I definitely don't want to rule out forecasting. And it sounds like I might be a minority right now. So I wanted to get that on the record. I think forecasting is critical.
Thank you. Commissioner Flocon?
Thank you. I actually agree with Commissioner Bond that I don't think we should rule out forecasting, because I think it's, as technology, especially in the healthcare field, it changes so rapidly that we can know ahead of time. We do have indicators to know what's coming. And I think it's kind of important to not, box us in just on the historical. The other question I had to Michael was, when we look at historical values, how far back, or how quickly do we have that information? Is it like we have last year's information that we can pull from, or are we talking like 2 years behind? So in terms of that data, how far back would we look? So just wanted to keep that in mind too.
So it depends a little bit on the indicator, but usually there's not more than a year lag. And if you want to use historical, then my recommendation is you want to use a long time period going back, because that's the only way to get the ups and the downs included.
Okay, thank you. And just to point out, Commissioner Flood dropped in the chat that she agrees with all of these points. I just want to make sure that the public was aware of that too. Commissioner Van Houweling?
I actually going to go back to Commissioner Bond, because I would like her to talk a little bit more. I don't think you're in the minority in this, Bobette, at all. I think, and I agree with your forward thinking, because we are able to get some projections. We all do it in our own companies, and especially with the advisory committee that we selected that has the ability to pull data and look forward, and both on the IT, but the analytical side. So, I'd like to actually go back to Bobette and kind of maybe if she can keep talking on that, because I don't think, I definitely don't want to rule it out, but looking, as Michael said, it's just a longer period, but the forecasting may be a shorter time period, maybe a year, 5 years, 10 years. So I don't want us to if we can have both, that would be great. So, Babette, if you wouldn't mind, I did like what you said.
Thank you, Commissioner Van Houweling.
All right, who else is on the line so we can move on?
Well, let's, I think it's Commissioner Bond, and then we have Commissioner Roa-Dugan.
I don't have a lot more to say on it. I just think that I'm driven by what the other states that were presented today are doing. They're forecasting. I think what we could do is embed our history into some baseline, you know, and then take from our baseline. We need help. We need forecasting help, what we would do going forward. And, you know, maybe at first we would do it based on a shorter time frame, like a 4-year forecast. And as we get better at this and more accurate and get more involved, we could extend it to 10 years. I don't know what that does to the trend though, and I would defer to Michael to help us understand it. But I just don't understand.
So I'll note, Babette, that all forecasts are informed by historical data.
Right, they would have to be, right?
Yeah.
That's how they get there.
Yeah.
So it's more about how we use how safe we feel about how far out we would forecast is the way that my work works.
Mm-hmm.
Hey, and Michael, I think just to add, I know we talked about CPI and using that, and there's a lot of consumer price indices that we can look at, but often and we use that in our own organization, what supply is going to look like, what's labor going to look like, pharmaceuticals. So we can utilize that as a tool, and I'm sure you do, since we talked about that earlier as being one of our main indicators for forecasting.
Mm-hmm.
Thanks. And I've got Commissioner Roa-Dugan, and then we're going to go to Dr. Sonam.
Yes, so I was going to mention that I actually asked Michael if there was a possibility that we could mix both, like Bovette, Commissioner Bond was saying, use the historical data to make our forecast values. So I don't know, Michael, you said that you would use the historical data anyways to make the forecast. So you answered my question, but I'm open to using the forecast. I guess if we can go into more detail on how we would do that.
Thank you.
All right.
So Dr. Sonam?
Yes, just quickly. I'm not opposed either to forecasting. I think that to the degree that the forecasted values are engage multiple data sources in the forecasting, and those data sources are valid and reliable, I'm okay with that. I think the question is two parts to the question, Michael. Once the methodology is established by states, how does it? Is that it? At what point does it change? So I'm going back to something Dr. Barron said at the beginning of the meeting, which is at some point we have an all players claim database, which would be essential for helping us to forecast appropriately in the future. You know, today we pick a historical approach. There's nothing to say that at some point in the future we might be smarter and have more data sources available where we might be better informed to do a forecasted approach. And so it seems like we should be able to change our mind at some point in the future if appropriate new developments occur that allow it to be more robust. Accurate?
Yeah, you have lots of flexibility here. I mean, all states that set them for multiple years pick a future date when they're going to pick it for the next time period. And, you know, unless it's in statute, which it's not for you, you've got lots of flexibility. So if you want to change your methodology after so many years, you can do so. There are not any states that, as a practice, annually revisit their entire methodology and their benchmark, because as you might recall, one of our criteria was to pick a benchmark that was going to give stability and predictability. So everyone picks something for multiple years. If they do a revisit, it's because they want to be sensitive to a possible substantial change in the economy, so they can consider whether they want to make a change. So for example, in one state, they say that if there's a spike in inflation, then they may revisit their methodology. Rhode Island had language that says if there's a major macroeconomic change, they might revisit their methodology. In fact, there was one and they decided not to, but they had that, trap door to use if they wanted to. You can define it though, however you want to.
Thank you.
Okay, looks
All
like
right.
that concludes everybody's, I have no other commissioners wishing to speak at this time.
All right. Thank you, Sarah. Can we move right along? How far are we with our time situation in the presentation?
I think we're good on time, Chair Khan. Michael, I would defer to you on your timing, but we are more than 3/4 of the way through Mr. Bailiff's presentation.
We're doing great. All right, so my takeaway here is that you are decidedly undecided on whether you want to do forecast or historical. That's fine. So now I'm going to share some values with you. I want to establish an expectation that we're not going to make a decision today, but I would like to get some sense of what interests you so that I can prep for our next conversation. And if that includes developing a couple different scenarios for you to look at, then I can do that. But I want to establish an expectation that you don't necessarily have to agree on a recommended benchmark, methodology, or value today. Okay, so I'm going to share historical data. It's going to be 20-year straight averages. There's no smoothing. These aren't median. This is just how we did it for purposes of giving you the information today. We didn't pick 10 years because it would overvalue the Great Recession. And the data that we have right now, generally speaking, don't reflect the COVID-19 pandemic's effects. The forecasted value for everything except for Pgsp came from the Governor's Office of Economic Development. And we, meaning our Baylor Health team, calculated Pgsp using the formula that I shared with you before. Okay, so I'm going to share with you for the 4 economic indices, historical values and forecast values. And then I will share with you what has per capita healthcare spending growth look like in the state for Medicare, Medicaid, and commercial. All right, so here you have the values. It's surprising how similar the 20-year lookbacks and forecasts are in some cases, but as I noted earlier, forecasts are all informed by historical experience. Okay, you can see here, and we see this in just about every state, well, actually in every state, gross state product is higher than personal income and wages. That's because the economic benefits of economic growth have not been accruing to workers fully. So that's why this is not just a Nevada phenomenon. We see this in other states as well. Higher economic growth than personal income and median wage. And for the reasons I explained earlier, median wage is historically been below personal income. The forecast you can see actually has it being above, but historically it's been below, and we see this in multiple states. And that median wage is pretty low relative to some other states.
May I ask a question?
Yeah.
I just need a little bit more interpretation of this. Just looking at the first row for the gross gross state product, 4.3% historical, 3.5 forecasted. Interpreting that, if I'm interpreting it correctly, that would be the healthcare cost benchmark. That is the healthcare cost relative to.
No.
Okay, so I need an interpretation of this 4.3% versus.
Sure. So the state economy on a per capita basis grew 4.3% per year between 2001 and 2020. And it's forecasted to grow 3.5% per year between 2021 and 2025. Okay, personal income in the state grew 2.7% per capita 2021 to 2020. It's forecasted to grow 1.9% 2021 to 2025. Now, part of the gross state product and the potential gross state product is healthcare because it's a big chunk of the economy. But this is total economic growth.
Michael, this is awesome. This is a great table because it really does take everything that you've talked about over the last how many hours we've been here and consolidate it into one place. Not only on the different approaches to benchmarking, but the methodologies based on historical or forecasted approaches and integrating those conceptual models. This is a very helpful table. Thank you.
Sure. So any questions? Because then I'd like to share with you what healthcare spending growth has looked like so that you have this, that is context, because you can't really make a decision without knowing that. Howard?
Sorry, yep.
Yeah.
Dr. Barron.
Yeah, thank you. I think one point that you mentioned earlier that, going forward, we should maybe consider is even if we do the forecasting, let's say for potential gross state product, tempering that with the median wage forecast, which is very similar to the historical, is good. And you made the statement before when you presented this slide that Nevada is a little bit different and the median wage is a little bit lower than you might see in some of the other states in comparison. And so I think that going back to our previous discussion about which of these indices might we use, maybe the right answer is a combination of those two things, seeming since we seem to in Nevada have a unique situation with regard to median wage, and that might temper our enthusiasm for our forecast going forward. Just my thoughts.
Yeah, and as you might recall, that's what Connecticut did. They did a weighted average of those two indices. So that certainly is an option.
When they use that weighted average, can you, maybe that now is not the time to have that conversation, but thinking about that algorithm, like what are they using to do that weight? Is that too complicated for today to even discuss? It sounds complicated given my experience with weighting data. I'm just wondering how that would work.
So it was a discussion by a group like yours. And there were some who thought that GSP, or actually they were using Pgsp because they're using the forecast. There are some who thought that it should be weighted more highly, and others that thought that median wage should be weighted more highly. And, they negotiated it out as a group and they came to consensus eventually. It was as simple as that.
I'm still trying to make sure we're not jumping ahead because I want consumer price index on the table, which I said. And I'm a little concerned, Dr. Barron, when you say that you want to, that we would take one and temper it with median wage, because I just want to make sure we have the option to do the opposite. We could use median wage and temper it with something else.
Oh yeah, and you're absolutely right. And I don't mean to infer from that saying that the word temper that we would heavily weight the GPSP more than we would the median wage or vice versa. But I think it's worth discussing some combination of those two.
You can see here, Bobette, that median wage and CPI give you just about the same value. So you might decide you want to pick one rather than the other because of the messaging value it has, but practically speaking, there's not much difference.
Yeah, helpful.
And Michael, I was going to actually ask you about that point, if you don't mind. I thought I heard you say that the median wage was, or maybe it was even Howard, I don't remember, that the median wage, its reflection, the number, and its reflection on Nevada was a little underestimated. Was that accurate?
No, I was just noting that wages weren't growing very fast historically in Nevada. I mean, in fact, inflation was growing faster than wages, which, for a worker, that's not very good.
Mhm.
So that was all. I was just reflecting that it's been pretty modest wage growth
Got it.
relative to inflation.
That's helpful.
That's actually interesting because we passed, I think last legislative session to eventually get to a $12 minimum wage. I know we're not there yet, but that's interesting that even within that forecast, the median wage is still kind of stagnant.
Yeah. I can't explain it. All right, let me show you actual spending growth because that will put all this in context. So we have graphed out per capita spending growth for Medicare, Medicaid, and commercial. What we see across every state is that commercial spending growth is always higher than Medicare and Medicaid. Medicare and Medicaid, their relationship can be variable, but commercial is almost always highest. So here's the first graph that I have for you. And what you can see for Medicare is, really since 2011, the rate of growth has been pretty modest, except for 2018, we're talking about rates that are between -1% and 2.5%. So pretty slow per capita growth. And as we all know, Medicare is a price giver. They have total control over it. And so that gives them a fair degree of control over spending. Okay, and I would say not a lot of volatility here. That's quite different than what you're going to see for Medicaid and commercial, where there's been a tremendous amount of volatility. So this is Medicaid. This is super high volatility. Here going in state fiscal 2019 from 7.5% growth to -0.6% growth a year later. So that's a lot of jumping around.
Could you speak to this and say why this might be, or?
I can't. So I would have to have a lot of contextual information about the Medicaid program and why this would have happened. So no, I can't say. I'm surprised by how low the lows are and how high the highs are. Especially because Medicaid also has, a fair measure of control over its spending, not complete at all, but it has a fair, it's got a lot of influence over its spending.
Could I ask the other commissioners maybe what they think? I mean, so what I would imagine, and I don't even know if this is accurate, but is that we've had such low prices on Medicaid. This is the narrative in Nevada. It was so low for so long. Medicaid was really trying to get the cost up. And then from 2019 to 2020, we were so concerned about COVID and our budget that they slashed Medicaid prices to providers. I don't know. And maybe, do you think it has to do with COVID as well, or no? I guess that's 2019, right?
Yeah, so state fiscal year 2020, part of that decline is probably due to COVID because people stopped accessing care, right? And the fiscal year runs through June of 2020. So some of this is COVID for sure, okay? This could have been provider rate increases these years. I don't know. I don't know why these figures are so low over here, but I would say, Jessica, that this -0.6% is at least in part influenced by that, March through April, May period where people just stop seeking care.
And probably provider rate decreases too, maybe.
I don't know about that. I don't know, but I know there's a big drop in utilization.
Okay, no, I don't know, Commissioner Bond. I'm just trying to understand it. So if you have insight, I would love that.
I think this just tracks what our experience was with access. So this matches pretty close to our access graphs on the reduction, because this is per capita growth, right?
Right.
It's not per capita spent. It's not how much the doctors made as much as how many people used. It's utilization side of this conversation.
No, this is per capita spending.
Okay. So it's both.
It's both price and utilization.
Okay.
Dr. Barron.
Yeah, I was gonna echo the same thing. I think that the drop certainly from 2019 to 2020 has to do with not accessing services, and that's why that's why there was a sort of a big discussion in the legislature about whether or not the 6% cuts during the special session to providers and hospitals and so forth was necessary, because there were some significant millions of dollars of cost savings and lack of access during that past year. I was going to comment that prior to that, if Medicaid enrollment is increasing, and I realize this is a per capita number, all you have to do is enroll, a handful of patients who have, significant spending on healthcare costs, transplant patients, et cetera, and it tips the curve upward pretty easily on a per capita basis. So my suspicion is that the peak before the drop during COVID, which I think is entirely COVID related, could have to do with enrollment numbers were kind of gradually increasing prior to that as well.
Could we get Director Whitley to weigh in on this, since he oversees the Medicaid program? He might know more than we do about what these numbers mean.
Sure. I think Suzanne is on as well, but I mean, I don't want to just conjecture. I think
right.
I really would rather. I mean, there are some events that have occurred. I actually think if we had our analyst overlay some events that occurred from enrollment to utilization, that all those, it could be all of those things.
That'd be helpful.
All right, let me share commercial. Commercial is every bit as volatile. So the red line is the total market, but we have a breakout. Whoops, sorry, didn't mean to do that. We got a breakout here of individual, small group, and large group. And this is crazy volatility. To go from essentially 0, negative, and then up to 15%, and then back down to 0. I don't usually see that type of volatility in a commercial market, and you can see it varied by group. So while large group and individual were spiking in 2019, small group was negative. But this is what we know, and this is why we're not going to be using any of this data for setting our benchmark. But if we want to get a sense of what the trend's been, we certainly have to look at multiple years to do so.
And I would just say this 18 to 20 does look like our data, which I guess we'd be in the large group market. I'm not sure you're capturing self-funded plans in the data, and that would be good to know too. But yeah, ours was all utilization because we didn't have cuts in reimbursement. So this is utilization.
Yeah, so this is just for insured lives because this comes from the Division of Insurance.
We're insured, but we're not in the large group pot, I think. Self-insured is still large group. Okay.
All right, so if we put this all together, this is what it looks like. And it's surprising that despite all the volatility, the rates of annual growth for both the longer time period and the shorter time period for Medicaid and commercial are, well, Medicaid, commercial, it's the same. We only go back to 2016, which is unfortunate. For Medicaid, it's the same. So, as I indicated earlier, commercial is the highest. It's always the highest. And it's that 4.1% is actually better than some states. In Oregon, it's around 6% what their commercial has been growing. And Medicaid and Medicare vary from state to state. But this gives you a sense as you look at the indicators that we could use for setting the benchmark value, that if we want to set a benchmark that's going to lower healthcare spending, it would have to be, it'd have to be pretty low to be below Medicaid, but certainly higher to be below Medicare and commercial. And ultimately, you're going to measure performance against the benchmark at the state level, at the market level. This is what I mean by market level, these three, at the insurer level by market, and at the large provider entity level by market.
So is it helpful to put all these together? And the other thing is you just showed us these huge outliers. I mean, volatility, and it's only 10 years. And you're saying that if we were going to look at GDP, we go back 20 years. Is it worth it to go back 20 years for this with all the volatility?
Yeah, so we can try to go back further. We'll have to ask Commissioner Richardson if we can go back further than 2016, because that's all the data that we were able to get. That's not very far.
And there was a 15% like increase.
Right, right.
So, like, I mean, the 4% to some extent, some of this is like not meaningless, but it's not saying, you know.
Yeah, I feel least good about this value because we have so few years for commercial. I certainly would like more years to look at commercial. You know, these figures are a little bit more robust. So we can look into that, Jessica, and we can also try to estimate what's a weighted average across the three markets for you for next time.
Well, I would just like to just point out that I think we did talk about it doesn't matter which measure, because over time it's, you know, it's all blunted. I think Dr. Slonim said something like it doesn't matter which one you use because you're going to get consistency in the end. But there's a big difference in trend, right? 4 times 4 years is 16% versus 4 times 2 years is 8%. So I think we should be very careful about knowing that just a digit makes a big difference in trend.
Yeah, it does.
I have Commissioner Van Houweling and then Dr. Barron. Commissioner Van Houweling?
No, great conversation, and then really focusing on this one particular slide. And again, here we are when we're looking at historical. There's a lot of footnotes related to periods of time and some of our memories related to timing, especially with COVID. But Michael, is a couple questions. The annual growth rate for Medicaid, Medicare, and commercial, that's on spend, correct? Not utilization or cost. It's just on the spend rate.
Per capita spend.
Per capita spend. So just qualifying that, and not so much actual utilization, which I think our commission needs to look at that too, is who's utilizing healthcare and what type of setting, and making sure that, as Dr. Slonim talked about, access in the appropriate setting, so to help drive down the cost. But as you look at Medicaid too, and we know, I'm not sure who brought that up, Commissioner Bohannon or Commissioner Flood, I believe, but we know that the Medicaid rates have kind of been manipulated due to budgetary constraints, and we all get that. And we appreciate, I'll go on the record right now, the governor and Mr. Whitley and others restoring those rates recently. So we appreciate those. But as we know, that rate is dictated on a lot of things, and then commercial is dictated on a lot of things of truing up or catching up or renegotiating contracts. So I just, you know, these numbers, I always say healthcare finance is never black and white. There's a lot of gray area, and trying to explain why things move and why certain indicators have impact on others. But just for clarification, this is on the actual spend, correct, Michael, from year over year. So it's not a direction on where we need to go, but it's just a reflection on what we've actually increased year over year.
Correct.
Okay.
Is it my turn to answer?
Yes, it is. Sorry, I thought Dr. Barron. And then we're going to go to Dr. Slonim, Bohannon, and Bond.
Great. You know, I think I totally understand that this is based upon spend, you know, and so forth, even in the absence of an all payer claims database yet. But I think one thing that would be interesting for the commissioners, just as we think about this, and also to sort of chart as we move forward on whatever we choose, it would be interesting to be able to track actual costs to consumers going forward as well. And I don't know if we have historical data on that, and overlay that with the total spend, so that healthcare dollars that are being spent overlaid with what the actual out-of-pocket cost to consumers has done in terms of its growth rate over time. So we had that one spike that you pointed out in your graph of spend and so forth, and that probably translated into rate, significant rate increases around that same time for most people. But it would be really interesting to overlay the graphs with actual cost, consumer spend, with increasing co-sharing of co-pays, insurance, deductibles, etc. I would like to see what the rate of growth of those kinds of things are compared to the rate of spend, and going forward, that might inform us as to whether our benchmark ultimately did translate into any sort of an improvement for the average consumer. As you pointed out earlier, some of the states like Massachusetts haven't really seen that translate into a cost savings for the consumer, even with the benchmarks put in place. So it would just be interesting for me to see what that is now and then be able to compare it in the future.
Yeah, a couple thoughts in response. One is, I don't know that there hasn't been a benefit to consumers in Massachusetts, but what we do know is that out-of-pocket spending for consumers in Massachusetts has grown faster than their benchmark. That's what we know. That doesn't mean that there haven't been savings. It just means the spending's been above the benchmark. And Howard, we don't have the type of information that you're seeking. It would require analysis of an APCD, or at least of the State Employee Health Plan, a PEB. But Connecticut did an analysis of their commercial spend, looking at total growth 2015 to 2018 and consumer out of pocket. The total growth was 15% between 2015 and 2018 for commercial. The consumer out of pocket was 26%. Okay, almost double for the consumers what it was for the total spend, because the total spend is inclusive of the consumers, but just the consumer portion, and just the out of pocket, not the premium, 26%.
Is it Dr. Sonam?
Thank you, Sarah. And Michael, I have to admit, I love the way you've done this whole presentation again, because incrementally, as you're giving us more information, it's actually changing perspective as we go, which I think is helpful. I mean, you had one set of preconceptions before you presented this data, now you've got healthcare data and there's a new frame on it, so it's very helpful. A couple of comments. So that stepwise approach is really good. I'm wondering about, has any state adjusted cost growth by payer type? Have they segregated out Medicaid versus commercial, for example, in terms of cost growth benchmarking? And the reason I'm asking the question about, should we be limiting cost growth in Medicaid when the rates are so below the cost to deliver the care? Point one. Point two, from a, given the population of Medicaid, I'm wondering about the diversity and inclusion issues. So given how far behind we are in terms of, again, the quality measures and moving forward, particularly for patients in Medicaid, where access is a problem, where we know that members of our community who are more vulnerable based on minority or ethnic background may have even further decompensations in care, whether or not we've got appropriate adjustment, and maybe this comes out in the numbers if you ended up with broader perspectives, but wow, limiting cost growth in Medicaid when that's the most vulnerable population and the ones who are most disadvantaged in the way that they're accessing healthcare from a quality perspective seems to me to be inconsistent, given we're here to protect patients or the people who are there. And that's what's kind of running in my head. No answers, just a comment in the way that I'm interpreting your stepwise presentation.
Yep. Now, I will say there are states that have set their benchmark value at a level that's above historical spending growth for Medicaid. But there have not been separate benchmarks set by market. They've all been state level benchmark values that are then applied at those different levels below. But again, you all have, broad purview on what you want to recommend. So if you want to recommend something different, you certainly have the flexibility to do so.
Thank you. So we've got Bohannon, Bond, Khan, and Flood in the queue, and we'll start with Bohannon.
Thank you, Sarah. It's interesting. Every time a commissioner talks, it almost changes my mind. So this is such an interesting conversation. I like what Dr. Slonim was just saying, sort of made me reevaluate what I was about to say, because I'm thinking from my standpoint, of course, I'm really representing a consumer and the patient the closest. And so I feel like I'm always thinking I struggle to find out what the care for my cost, or excuse me, the cost of my care is going to be. But we're not really looking at that. We're looking at it from a population standpoint. And so that is important. And I think that Dr. Slonim brought up a very good point about, do we really want to limit what Medicaid spent, like thinking about Medicaid spending or even commercial spending? I think that we're going to see a lot of volatility in the next year. I think there's going to be a lot of services that are going to be made up for because a lot of people didn't seek care, a lot of people with chronic conditions, especially, and there could be some overspending that we're going to see. And so I think that's why obviously using historical trends and everything is so important. I'm really struck in this chart by the difference. It seems like Medicaid and commercial are very close, but then Medicare, there's 2 years in or taking the 2 years out, there's such a big jump. I mean, twofold, more than twofold. And I guess I'm just curious, something must have happened. And this is where kind of forecasting makes me nervous, because these are the things that it's so hard to forecast for that. And I think that 2021, 2022 are going to be some just really interesting years in healthcare, because we have so many of the so-called long haulers in COVID, and what that's going to do to healthcare spending will be interesting. I guess I'm confused. Do we tie something to a smaller growth rate in the interest of patients and consumers to keep costs down, or at least to try to keep costs down? Or do we also try to balance the idea of what Dr. Slonim was just saying, which is, do we want to make up for patients who have been vulnerable and may have additional healthcare spending needs? So I guess I'm left with more questions than decisions, kind of analysis paralysis here.
Thank you. Commissioner Bond.
Thank you. I think that one of the things that Dr. Barron said about, can we figure out cost to the patient? And you're saying, Michael, we don't have a really good measure for that. I think one of the big things missing in this conversation is we're talking about these numbers as though this is the cost of care, but this is just how much we pay for care. This is the price of care. We are not talking in this conversation about how much care actually costs the providers. And I think that that's an important piece of this, because while we're hearing about our low reimbursement in Medicaid in a lot of the conversations today, the profits of the hospital system in Nevada last year as a state was $500 million in net income. Net income. That's after people take the dollars that are sent out of state or allocate it to their home office allocation pot. So I feel in this conversation, we have to keep track of how do we actually track the cost of care to the providers if we're also going to try to track the cost of care to the patient, which we should. I feel like this entire conversation is talking about cost. Cost really means what we paid. It doesn't mean what the care cost. And I just want to always clarify that, because they're very different. And that's what we need to get to. Where is the compromise here?
Well, they're also interactive, right? Because the amount that's paid has influence on the cost that's incurred.
And the amount that's
And
paid
and
is
vice
tied to
versa in the commercial market.
is to the price, is tied to the price that's charged.
Thank you.
Thanks.
Commissioner Flocon?
Thank you. So I agree with Commissioner Bohannon that this is, the whole conversation has like really made me think of a number of things. I want to say for the record that I completely agree with the comments that have been made by Commissioner Barron and Commissioner Slonim on capturing the cost both for the consumer, because I don't think we have data. And Michael, to your point, there really is no good data collection source out there on the changes in spend to the consumer over time. And I think that's an important thing, because we are hearing both anecdotally, but we're also seeing in the numbers that the cost to consumers, regardless of whether you control cost, it continues to go up. And it's going up at rates higher, as you just mentioned, like you saw in Connecticut, almost double what the actual cost might be. So I think there is something there. With respect to the Medicare data in your chart, Michael, I'm curious to know, how are there tracks and changes in terms of population? Because obviously Medicare is age-based, right? So once you hit a certain age, so are there population trends that we're looking at that could account for some of that change? And then also shifting of populations from one state to another. As we know, as people go to retire, they're looking for places that they can go, and Nevada being one, because of the lower cost of living in some of the, as compared to some of the neighboring states. So you could see migration into the state. So I don't know if that's having an impact on those numbers, particularly in the time frame that you were looking at. So curious to know, are there, when we're looking at the data, are we looking at those cost trends as well, or trends to the impact that could be?
So we haven't adjusted this for anything. You could say that, if theoretically there was a big influx of retirees who were Medicare eligible, they would be younger Medicare enrollees, so their per capita spend would be lower than older Medicare enrollees. But this is just looking at total spending without any adjustment or interpretation.
Okay. Thank you. That's helpful.
Thank you. Commissioner Flood?
Yeah, I just want to step back for a second and say I really enjoy this much of a deep dive on one topic. Like, this is really nice. I think probably all the commissioners feel satisfied by being able to chew on something like this. And in terms of the cost to consumer, I feel like that will hopefully be a whole nother topic like this, where we can really drill down. Because I even heard recently, I've been trying to read books, but that they were saying that employers are starting to choose more high deductible plans. And so it would just be interesting to know all the drivers in cost to consumers. I really appreciate Dr. Sloanim's point on this Medicaid piece, because I agree with Commissioner Bond that, there has been like a lot of money that the hospitals have made, perhaps, right? But it's more nuanced than that. I know I work a lot with community providers, and they continually say that they lose money on Medicaid patients, that is just like not enough money to stay afloat. A good example, and I don't want to get too far into this, I know we talk about dental and it just turns into this big thing, but a lot of dentists in Nevada don't take Medicaid at all because it's actually a loss. So if we were going, I just wonder if there is, this sounds kind of crazy, but if you could carve out Medicaid, and maybe that's a really bad idea, but it just seems like if we already are starving, and let me back up really quick. So I've been reading Priced Out. I just started it. I'm just trying to be transparent. But he made this comment that in New Jersey, Medicaid rates are 1/3 of the cost of like commercial insurance. And what we're actually saying is that we value care for those with a lower socioeconomic status lower than people with high socioeconomic status when we like pay so much lower for it. So I thought that was an interesting comment. So I just was interested in Medicaid, and I could be way off on all that, but those were just some of the thoughts I had.
I'll say, if Medicaid spending on average, Medicaid spending growth on average is low, and you set a benchmark value that is above it, what the growth rate has been, then it's almost immaterial. When you're setting the benchmark value, you're really focusing on this bottom line of the table, because that's where the growth rate is highest. And that's the population that's going to generate, or that's going to receive the greatest benefit from having a benchmark, if the benchmark is successful.
So that's my question. Are we going to weight this average, and then like that weighted average, commercial would be more affected? I guess I just worry that we're going to look at each one of these, because you were kind of saying that you would look at each company and they would need to kind of be like, oh, we're growing faster than this benchmark. What are we going to do? Would Medicaid go, oh, we're growing faster than this benchmark. What are we going to do? When really it's a boon year. We get some money in Nevada and we're trying to bolster Medicaid.
Yeah, so in the other states, the process is that they do the measurement and then they interpret it. So if Medicaid, let's say I'll pick 3.7% just because it's on the slide. Let's say you picked 3.7%. Medicaid's running, 1.3% below that every year. Let's say one year the legislature says we're going to do a big one-time increase in rates in Medicaid, and it bumps up to 4.5%. So what would happen that year is a body like this one would say, all right, Medicaid went over this year, and we know why. It's because the legislature decided to make an investment. That makes sense. That's a justifiable increase. Okay. But if we look over at commercial and it was 4.5%, you would say, no, that's not justifiable. We set the target at 3.7, 4.5 is too high. So know that, there's the ability to annually interpret the results.
Right.
And especially because there are no penalties or sanctions for exceeding the benchmark. There might be a little bit of public embarrassment, but to the extent that it can be interpreted and you can message what's justifiable and what's not, I think it's okay.
I just would hope, and I'm just throwing it out there for unanticipated consequences, that there isn't an unanticipated consequence of a dampening effect on Medicaid when it's, I would say, speaking from the community provider perspective, like outpatient, that they're being starved to some extent, whether that's true or not. But yeah, that like the legislature doesn't take that benchmark, or Medicaid doesn't take that benchmark and kind of roll with it, So I just want to put that up.
I mean, so Medicaid has to manage to the state budget allocation every year, right? That's what they're going to manage against, and usually the pressures on the state budget and on Medicaid are significant, and that's not going to go away.
So I think we need to move right along. We have a couple of more agenda items. How far are we in this process?
So what I'd like to suggest is that for the next meeting, I put together a couple of scenarios for you based on your interest in gross state product and in median wage. And I come back to you and show you what the benchmark would look like under 2 or 3 different scenarios. I'll also see if we can roll these up to give you a statewide historical. Maybe we can follow up with Commissioner Richardson to see if we can get a little bit more backward-looking data for commercial. And then we can have a second conversation about setting the benchmark and see if we can reach a preliminary recommendation.
So I think that sounds all right from my point of view. I think we have had very excellent, very engaged and thoughtful input from every commissioner at length. So I hope that helps you or guides you for the state of Nevada. What are the interests of the commissioners to see from you at the next meeting to elaborate further and narrow things down that sort of match up with the commissioner's thought process. Does that make sense?
Yeah, and Chair Khanna, what I'd like to also remind the commission about is the establishment of the stakeholder advisory group. So we'll anticipate trying to put together a meeting in between your next meeting, so you'll have some additional feedback from that group.
Yeah, and that's very, very helpful. Will also be very helpful. So moving right along, Sarah, where are we next? We wrapped up this one.
Yeah, Michael, I just wanted to confirm you're concluding your presentation. You're good? Okay, great. So Chair Khan, if you are ready to move on and close out agenda item 6, the next agenda item is my update to the commission on their pending legislation and legislative activities for an informational update.
Right, so let's open it up with your presentation. And we've allocated 10 minutes for this. So if there is any input from commissioners on this update, we would like to hear. Sarah, please proceed. And
Sure. Thank you so much, Chair Khan. So commissioners, the most recent update we'll start with Senate Bill 5 was the update that I sent to you on Friday, announcing that Senate Bill 5 did make it out of committee with a recommendation to amend. That is, so the next step for Senate Bill 5 would be for the full body to adopt that amendment and then consider a final vote on that measure. But since it's been modified, I do want to note that the originating House, Senate, will actually have to concur on that amendment. And so if they do not concur, then there's another additional step for the Senate to then either rescind the amendment or not concur, and then it would go into a conflict meeting. So good news that it got out of committee before deadline, but I don't want to make any set any expectations that it is a done deal or moving. So there are still a lot of steps in the legislative process for Senate Bill 5. Senate Bill 40, the Commission's bill on transparency and establishment of an all-payer claims database, is exempt from any deadlines, but it's still in its originating House and working its way through Senate Finance to deal with the fiscal note. So it still needs to move out of Finance, and they need to approve it before it can go to the floor for a vote. I'm hopeful that there'll be some consideration for a work session on Senate Bill 40 relatively soon. But it does need to get out of the originating House and over to the Assembly. The legislature is set to adjourn on May 31st. So it is short time frames for both of these measures.
all right, so there was another bill, and one of my senior moments right now, and maybe Commissioner Barron can lighten up my bulb in the brain. Howard, would you mind? There was another bill, I think one of our commissioners that mentioned.
Yeah, AB 348.
348.
Sure,
so what's the status on that?
Sure, I'm happy to talk about Assembly Bill 348. I do want to recognize that this is not the Commission's bill. It is related to the Patient Protection Commission, but the sponsor of this piece of legislation is Assemblywoman Maggie Carlton. And what I can tell you is that bill has been modified and adjusted, but it has passed out of the originating House, and so it's in the Senate, but it was just recommended to do pass out of the Senate Committee on Health and Human Services. It's a little bit awkward for me to talk about this piece of legislation because I'm going to try to summarize this in the testimony from the sponsor, Assemblywoman Carlton, as well as Chair Ratty in her decision to work session the measure and move forward. So Assemblywoman Carlton, quite frankly, feels that the commission is not working exactly how she believes it was set up for. There are some significant changes to the membership that she's proposing, and she really is concerned with, I believe her testimony was industry flavor to the commission, and she really feels strongly that the industry needs to step back. Chair Ratty heard the hearing, and during the public comment period, there was no opposition to this piece of legislation. However, there were several associations, all of whom you are very familiar with and likely affiliated with in your own industries, including the Nevada Hospital Association, HCA, Pharma, and Nevada State Medical Association, all testified neutral, but expressed concerns with the modification in the membership. Chair Ratty decided at the close of the hearing that she would consider the bill for a work session, and she bluntly stated that she also doesn't believe the commission is working. And although she feels that there have been good and sincere efforts made, she was open to trying something new. So upon closing of the hearing last night, she opened it up for it to be considered a due pass as the bill is written in the first reprint and was amended by the sponsor. And the committee voted it out of commission last night. It was on party line votes, and that bill is now pending decision by the Senate body. I'm still looking over the membership, but should that move forward and get passed, there is going to be some significant changes to the commission makeup, in addition to some other provisions in the bill that outline, I believe, a mandated conflicts of interest statement for this commission and a formal adoption of bylaws. Now, the membership, Chair Khan, my best summary of it is that it will expand the current membership by one non-voting member, and that would be the executive director of Nevada's Public Employee Benefits Program. And there also will be an additional voting member from the state health information perspective.
All right, thank you very much. So any comments from the commissioners? Considering the time constraints, we are past 11 a.m. So any questions, observations, concerns, interests, apprehensions?
Yeah, and so it looks like I've got a couple of commissioners' hands up. It looks like in the queue we have Commissioner Flo Khan and Commissioner Bohannon. So we will start with Commissioner Khan.
Thank you. And for the record, I do want everyone to know that as a representative of Pharma, we were not as a commission member, but as Pharma, we did submit written kind of concerns to both the author, or so the sponsor of the bill, as well as to Chairman Ratty, about the removal of many of the folks who represent kind of the private or for-profit entities within the healthcare space. And the reason for that really isn't, I mean, we had no objection to increasing the membership so that you had more public individuals or more public representatives and for consumers. But I do think that removal of some of the key components and some of the key members on this commission is really going to eliminate expertise on how the system actually works. And we do think that's a failing of the legislature in recognizing the importance of having that expertise, because so much of what we're trying to do, we're all trying to do here, is figure out, find out the cost drivers within the system, and then try to come up with mechanisms to figure out how is the best approach to bring down the cost of healthcare, but at the same time making sure that you have quality of care for all Nevadans. And by taking away this expertise and limiting it only to public entities, I think is a huge mistake. And so, I can speak for that personally, but I also think, from our industry perspective. So I would have hoped that this commission would take an action to kind of send a message of concern to the legislature on where we think, if we think this is a good policy.
So thank you so much.
Who's the next one in line?
Yep, thanks so much, Commissioner Khan, for your feedback on that. I can say, just to add to that, that is a fundamental disagreement that was had during the hearing amongst the legislature, and it really is in the jurisdiction of the legislature. And there are folks at the table who are speaking with the sponsor, but I do want to make sure that the commission is aware that this bill is not anywhere in its jurisdiction. But if you do want to consider working with the sponsor individually. And like I said, I believe the associations that you all are affiliated with are at the table and did testify last night.
Okay, who is next? Commissioner?
It looks like I've got Commissioner Bohannon, and then in the queue is Commissioner Flood.
Okay.
Thank you. I read over AB 348. I don't know exactly how I feel about it. I know I do feel that consumers and patients should be more represented. I was very disheartened to see that Senator Ratty feels like we're just not working. I kind of understand where she might be coming from, but it is also, very kind of upsetting as a commissioner representing patients as, a consumer. And so I would support seeing addition of more patient voices to the commission. I don't think that would hurt anything. And but I also understand the idea of industry. That all aside, I was wondering, Chair Khan and Sarah, if it would be possible after legislative session to maybe have a nice deep dive into all the bills that actually got passed and are going to be signed into law, and we can talk about them and how they will impact patients. I think it might be a worthy exercise for the commission to really kind of see how some of the new laws are going to impact patients and just kind of having some reflection on it. Just a suggestion.
So I have no problem with that. I think it's a good idea. So we can certainly look at that if the commission exists as it is today after the session is over. So we'll find out. So if I may just put in my personal opinion, not as the chair of the commission, obviously, I am really disappointed, to say the least, about the opinion in the legislators' minds that the commission is not working. As you all know, all the commissioners have put in an inordinate amount of time in deliberating on the subjects that were in front of us, and certainly keeping in mind the priorities outlined by the governor in this whole deliberative process. So I'm really disappointed to hear that the commission is not functioning. It may not be doing what the legislators in their mind thought should be happening. And there is always room for modifying the subjects to be addressed and brought to the commission. But certainly the time and effort put in by this commission and individual members on a voluntary basis, I think is exemplary. Meeting so often despite the COVID situation for hours, 3 hours, 4 hours, and at one session even 5 hours. So I think that's a little disheartening and very disappointing, and that's my personal opinion. So let's proceed with who else wants to speak.
Sure. Thank you so much, Chair Khan. Commissioner Flood?
Yeah, I really agree with the prior commissioner's comments. What Commissioner Khan said, I think, is so right on. I really believe in collaboration, and I agree that there probably needs to be more consumer voice on this. But collaboration is tough. There's storming, forming, norming, performing, and I told Sarah this at the beginning. Like, that conflict is uncomfortable. But we started, I think, to really establish trust and norms. And I think by resetting the commission in some ways, you're going to get the same thing to some extent, at least at the beginning, right? Because everyone's kind of like, what is this new thing and can we trust it? So I would hope that we could keep some diversity on this. The other concern that I have is that there's no rural voice. It doesn't feel super statewide. I think the One Healthcare Association is down in Clark County. And so it just is concerning that we don't have diversity of stakeholders, or we won't with the passage of this bill.
All right, who else is in line?
There's no other commissioners in the queue.
All right, any other comments on the presentation of these bills moving in the legislature.
I just want to agree with what Commissioner Flood said. I think definitely there's, we've gone through the storming phase. There's no doubt about that. I don't know that shaking up the commission is going to get the results that people want. I think that there's a lot of need and desire for there to be healthcare reform and immediately, and for the lives of patients to be changed. Has my life as a patient changed fundamentally since the, adoption of the PPC? No, but I don't think that that should be the expectation. There's a lot of hunger and desire for things to happen and to happen quickly, because patients are in need and they need things to happen. But I don't know that shaking everything up is going to get us across the finish line any faster. And I totally agree with what Commissioner Flood said. And I agree with you, Chair Khan, on your personal opinions.
So if I may add on following up on that, is if you keep in mind, we had the option when we were created of at least 2 BDRs that should be considered and submitted. And after a lot of deliberation, the commission almost unanimously agreed on 2 subjects. And so those 2 subjects in the wisdom of this commission were considered important and to be addressed at this point in time. And after due deliberation, they were obviously passed on to the legislature, and it's the legislature's right to modify, change, amend, etc. And obviously, we don't have much say in that as a commission, and we have not done that, and rightly so. So having said that, after those 2 BDRs, this commission was advised by the executive office to consider this Millbank subject, which is also very significant. And we moved on to that one, and we are very aggressively pursuing that also on a regular basis in the meetings. So we have followed the process as was advised. Whether there's room for modification and change in the commission, perhaps yes, based on certain stakeholders that were mentioned earlier by a couple of commissioners. But again, unfortunately, that's beyond this commission's jurisdiction, but individuals can certainly go and testify at the legislature and give their input over there.
Thank you, Chair Khan. And if I can, I would be remiss if I didn't also point out that the sponsor, Assemblywoman Maggie Carlton, did mention in her testimony that this was not directed at any one particular commissioner, and she really felt that it was just necessary because it was a shift in her perspective of the commission not functioning the way she had anticipated this commission functioning when she initially supported the measure to create this commission. So I hope none of you feel that it is a personal piece on each of you, and I certainly have appreciated all of your engagement and continued work collectively.
All right, thank you. Any other comments before we wrap this agenda item?
I do have Commissioner Bond raising her hand. Yes. Did you want to speak? Okay.
Yeah, I just want to thank you for your comments, Sarah. I think that trying to introduce this topic is awkward, and I think that you did a great job of summarizing the hearing. And I understand that the commission as it stands now wants to stay the commission as it stands. I understand the interests at the table, but I really appreciate so many commissioners speaking up for the need to add consumers and a patient voice. And I think that is, I think that there has been external attention on our lack of that and our industry focus. So I thank you, Sarah, for trying to present this.
Thank you. Any other commissioners with comments on this? If not, then we can move on to the next agenda item 8. This is a standing agenda item, discussion of potential agenda items for future meeting for future and future meeting dates.
Yeah, Chair Khan, if I may,
I think, go ahead.
If I may, under this topic, I'm so sorry, Attorney Ott, for putting you on the spot, but I do think it is important to recognize the kind of the logistics and the dynamics of kind of hosting public meetings going forward, particularly in June. And I would really like for him to speak upon our options as a public body after this month. So, Attorney Ott, are you available? He might be having some difficulty. So what I just really want to make sure that everybody is aware of is that we have the flexibility of being able to meet virtually now under current directive that is actually going to dissolve at the end of this month. So there is a pending piece of legislation that will allow for the continuation for public bodies to meet virtually. But should that not pass and should that not be an option for us, we need to work very quickly and very creatively to find a public space. And I will not have the capacity to host a meeting via Zoom unless we're given that as an option. So the commission has a meeting on schedule for June 16th. That's the third Wednesday. However, I really want to make sure you're aware that we are in some changing times and I may not be able to put together a virtual meeting. And if so, we are struggling to find public meeting space that could meet our demands. And so I might furiously message some of the commissioners for some creative ideas, but I just want you to know about those logistics that might press upon us soon.
So if I understand correctly, we may or may not have some clarity by then. Hopefully the legislature has ended on the 31st of May and they may have decided one way or the other, virtual or otherwise.
Right.
So
we will have clarity by the end of the legislature.
Right. So
concluding
having
their
said
business.
that, the challenge you have or we have as a commission is when and how to meet, given the short notice. If they decide continue virtually, that's one thing. If they say not virtually, then that's your real challenge to find the space in a timely manner to decide if we are going to meet in person and keep that date as is, or try to move that date if it has to be in person based on the availability of space, et cetera. Is that a correct assessment, Sarah?
Yeah, and we'll have to, try to make sure that everybody could meet in person or dial in. And I really need to figure out the logistics of our options to meet in June. So it was a really long-winded way of me saying to be determined, just so I need to make sure that we have the capacity to meet. However, virtually or in person or a combination of both. And it's still not clear to me what our options are.
So I agree. So let's keep this, if nobody has any objections, that to be determined the next meeting based on the scenario that we have just discussed. Anybody has any objection to that date to keep it flexible for the June meeting at least? Hearing none. So Sarah, then that's what we are going to do. We'll hear from you how things are developing. And then we'll keep the June date as, to be determined whether to hold it or not hold it. And if at all hold it, depending on what the legislature has guided us. So any other comments on the potential agenda items? We are still dealing with the executive branch's priority on Millbank. So that is taking a significant amount of our time, obviously. Any other agenda items in anybody's mind?
We left off the discussion of the development of subcommittees, but it may be worth tabling if the commission is shook up. So, I mean, I would still love to see the formation of additional subcommittees around workforce development and like quality and accessibility or other, issues for consumers. But I don't know if maybe now we do need to table it and see what happens with AB 348.
That's my understanding. I think we may have to just table that till we see what, moves out and comes out of it. And then wait for our next meeting to figure it out. Whenever that next meeting is, whether it's in June or later, based on what we just discussed. Does that make sense to everybody? All right, so hearing no other comments, the last or second last item is the public comment. Do we have anybody in the north, Sarah?
Sure, let's just take a pause. So members who are joining us publicly, if you can press *9 by telephone to raise your hand, or if you're joining us by Zoom, please raise your hand.
Do you have anyone?
Sure, Con, I do not have anyone who is wishing to indicate to speak, and yep, I don't have anyone.
Anybody from the South? None? So hearing none, so that's the end of that agenda item. So last but not the least, does anybody want to move a motion to adjourn? I know you want to stay, but do you have a motion to adjourn?
I'll move to adjourn. This is Tony Sloan.
Second from
Second,
someone?
Mason?
Thank you. So anybody opposed? Hearing none, so we stand adjourned. Thank you very much again, everybody. I really appreciate the time. And I'm glad we didn't go till even 12 o'clock because everybody has got to go back to their own businesses. Thank you very much again.
Thank you.